It's Friday. Good morning, honorable members. Today is Friday, the 23rd of September, 9 o'clock, according to my clock, and this is the Standing Committee for Health. I welcome all members in the chambers. I do see Member Plato online. Member Plato did indicate in advance that he will be joining us online. I also note the Honourable Minister Mbombo online. Welcome also to all our procedural staff. At this point, I will now ask members to kindly introduce themselves, please.
Good morning, everyone. Member Christopher Fry.
Good morning, Chair and everyone. Rachel van Vogel.
Good morning, Member Bakubaku Force.
Thank you very much, members in chambers, members online.
Good morning, Chairperson and members. Dan Plato.
Good morning, Member Plato, and welcome to you. There's no other members online. I will then immediately go over to the department. Honourable Minister.
Thank you very much, Chair. I'm sorry I'm unable to put on my camera. We've got load shedding. We don't have the Cape Town load shedding schedule. We have the ESCOM one. But I just wanted also to acknowledge and thank the committee for raising this important issue, which is the mental health, especially during the time that we are coming from the COVID. And also, as we have seen research countrywide or even internationally, that not only COVID has impacted on the mental health status of people as individuals, but also it has impacted on the community status, mental health status. But I just want also to acknowledge the team that is there, because when the SC asks specifics in regard to who should be invited, we welcome that the coalface staff, which is mostly the CEO, are the ones who will be able to answer. So having said that, it's an apology on behalf of Dr. Pluti, but the people who are there as the request by the committee, the delegation is being led by Ms. Carol Dean, who's the director in the office of the Dr. Perez Chief Directorate, who's responsible for what now has been requested across the metro. And we have in the request, we have got the CEOs of the Khayelitsha, of the Mitchells Plain. These two are the district hospitals, and they are not psychiatry, although they now have these psychiatry units. And also as a district hospital, they have to do the 72 hours. And then in some cases now, they also have got some patients that some of them actually were supposed to be in the specialized hospital. And then we also have the CEO of Vakkenberg, which is a specialized hospital. We've got the CEO of Lendegier, which is a specialized hospital for the mental health. And then we have the acting CEO for Stekland, which is also the specialized hospital. When Ms. Dean does a presentation, she will pack more in terms of exactly what each, talking about the specialized hospital, what is that they offer. Having said that, Chair, noting that these they can only speak on behalf of the institutionalized patients and also the feeder area in regard to the epidemiology, where their clients, where they are servicing their clients. Part of this, the whole lot of people are outside. Some of them, they are under the community mental health services, not only as a daily patients coming to primary health services, but also as part of the NGOs that have been licensed by the social development, and then for also some of them in addition to double licensed by us. So the bulk of mental health patients, mental ill patients are actually outside. These ones are just institutionalized. And Ms. Dean also probably also has to reflect on the Mental Health Act on what guides us in regard to the mental health. Having said that, Chair, after, I'll be here until 9:30. After that, I will indicate when I have to be excused. Thank you, Ms. Dean. Over to you. Thank you.
Thank you very much, Minister. I thought you were just going to say good morning to us, but whilst you are audible, you made use of the time to give us a briefing as well. Not a problem. I just see another member joining us as well for the record member.
Good morning, Chair. Apologies for being late. It's Member Chako, member of the committee.
Most welcome, Member Tejo. Thank you so much for joining. I will now give over to the departmental officials in chambers to introduce yourself.
So
please.
good morning, Honourable Chair, Honourable Members. Thank you very much for having us. I'm Carol Dean, Specialised Hospitals Director. Sorry, Mr. Warren Caesar called in sick this morning. He was hoping to get the online links. I'm not sure if he's successful. And Mr. David Binzer might be online. My eyes are not that good to see so far away. So I hope he's online.
Thank you.
Good morning, everybody. I'm Charlene Goliath, the CEO at Valkenburg Hospital.
Good morning. I'm Estelle Silence. I'm acting CEO for the day at the Client Hospital.
Good morning, honourable members. I'm Evan Swart, CEO of Mitchells Plain District Hospital. Morning.
Good morning, honourable members. I'm Zuge Sigaba, Director of Restorative Services, that encompasses the following sub-programs: crime prevention and support, victim empowerment services, and substance abuse. Thank you.
Good morning, everybody. I'm Mashinette Jonkerman. I am Director in Social Development for Facility Management. Thank you.
Thank you very much, and thank you for being with us this morning. I do trust that we will have a most productive session this morning. And then we also have one of our regulars with us this morning. Ms. Kivitz, for the record, please.
Good morning, Damaris Kivitz, Cape Metro.
Thank you very much for joining us this morning as well. Ms. Jumke, did we receive any further apologies?
It was an apology from Member Barnes, Chair. She tendered an apology from the ANC.
Thank you very much. And the officials that indicated they'll be online, can you just check, Namunde? If they are indeed online.
Sorry, Honourable Chair. We sent an email requesting online connection, yeah. Mr. David Binzer particularly, and I asked Mr. Warren Caesar also to connect with him to get the online. Could we still send it? I'll ask Charlene just to send it on.
I don't have the link.
From the department, you just send the link. You can just ask her to send it to them. Yeah, not a problem. The Monday will make sure that she forwards the link. Then no further apologies. Honourable members and Minister and officials, the committee resolved to schedule today's engagement to have a briefing by the Department of Health on its mental health program after observing the severity of mental health challenges in various hospitals across the province, specifically the challenge of mental health at the district level in facilities such as Khayelitsha and Mitchells Plain, to name but a few. During our visits, members will remember it was clear that the committee also grappled with the challenge of mental health in the province and that it needs urgent attention. And hence we resolved to schedule this meeting this morning. The committee also extended the invitation for this meeting to the Department of Social Development to come and brief the committee on the programs that they have in place to address the social determinants that apply pressure to the health system, specifically in the Khayelitsha and the Mitchells Plain district hospitals. Ms. Jamte, do we have anyone from the Social Development Department present, or are they joining?
Yes, Chair, Mr. Kaba.
Okay, sure. Thank you so much for that. We just needed to make double sure. At this point, members, if it's in order with you that we have the Health Department give us their briefing, We will then indulge with questions and answers, and after that, the Department of Social Development, and then we embark on questions and answers, and then we can also deal with our resolutions and recommendations. We also have quite a few of committee business to get through. So after social developments, questions and answers session, we will also, Ms. Kivitz, provide you after each presentation and members have exhausted their questions, also the opportunity to raise your questions. So after we've done with that, we will then deal with our business, and then we will excuse you to go about your daily business. So at this point, over to the Department of Health. Minister, is there anything that you would want to add from your side at this point?
Chair, I think I've covered everything that the presentation, the people who are there, they will be able to talk specifically in regard to their own institutions, because the request was for the institutionalized aspect of it, but the issue of the community mental health services and also on the Western Cape government, because it's a priority that's also within the Premier, and it is co-chaired by the Health and the Social Development and DICAS in regard to the mental health. They won't be able to answer some of those questions because the request from the SC was specifically on the institutionalized mental health services, hence the CEOs that are there. Over to you, Ms. Dean. Thanks.
Thank you very much, Minister. You may proceed. Thank you.
Thank you so much, Chair. How do I change the slides? Oh, there is an indication. So thank you so much. We did introduce the attendees. We can skip that one. Yeah. Okay, we've skipped a slide, but that's fine. Just wanted to contextualize that it is important to note that mental health has to be seen in a context of public mental health, and you'll see it in your presentation. I think it's also important to note that a population-based approach is critical. We can get more specific than that. We can talk about a community-based approach, and I think that will assist us with our discussion going forward. We have grown so much in mental health and we've got so much evidence, so nothing we do should be without an evidence-based approach. I think it's critical that we are sitting here today because it does encompass issues of political, economic, ethical dimensions when you speak to an issue of a community or a population-based approach. I think it's no secret that, sorry, the slides are going ahead. I'm on the first slide. Yes, thank you so much. I think it's no secret that we need to achieve equity in mental health, and we'll speak more to that as we go on during the day. Critical and underscored in all this, and I think no one can deny the importance that whatever we do has to take into account a promotion approach, prevention, even though we need treatment and rehabilitation. I think those things are interconnected. So yeah, mental health, as we all know, cannot be separated from your physical illness. It's interconnected and we shouldn't see it separately. So thank you. The next slide, please. So I just wanted to give you the definition. I think we've gone a bit too quickly there, but the definition of mental health. And mental health is defined by the World Health Organization as a state of well-being. And I think often we see cases who have come to our hospital who are acutely ill, but the general state of mental health should be that of well-being, where someone can reach his or her potential, can be productive in society, and lead a fruitful life like we all wish to do, and make that contribution to our communities as we so deeply understand. This slide is really not to focus on, but just to say there's a continuum of mental health. It starts with well-being, where we are well. Then it can move into the different states where maybe you have a few symptoms, but it's quite non-specific. And then it moves on to where you maybe need more specialized care or some intervention. and it can move on to quite an acute, serious mental illness. So this is just to say it's not mental illness or nothing. It's a continuum. Thank you. Next slide, please. So I want to go to primary health care. I think this is the most important vehicle that we're going to be talking about, because the primary health care approach has to push and support a promotion, prevention, and an adherence focus. Ideally, we want to keep people who are well. So what do we do for them to keep them well? And this is again in discussion with our community. How do we do it? What are the options? And we want to give those who need care the care they need. And once they get the care they need, keep them adherent, help them to be adherent to care, and then also keep them as far as possible out of our hospitals, because that's not the ideal. So at the primary health care approach, we have the CHCs, CDCs, but at the CHC, where we have the full package of care, we really promote an integrative approach. So you can come in to see the generalist, and as you need more care, they will send you on and refer you to people who are more specialized in the area. And many of our CHCs do treatment and rehabilitation, but they also have access to a multidisciplinary team or parts of the multidisciplinary team. More recently, we've employed the registered counselor at some of our facilities. We've got intern psychologists who do outreach, sometimes psychiatrists, registrars go out, sometimes we have psychologists at CHCs. So this is what our focus is going forward. Now, part of primary health care is also the community-based approach. And the community-based approach is critical because here we have the community health worker. And what we have increasingly done in the last while, when someone is discharged from a psychiatric hospital after an acute episode of illness, really ill, now you need medication, you need to be adherent. We refer the person to the community health worker in the community who does the home visit, who makes sure that the person takes medication. If there's a breakdown, to then alert the supervisor, and we try and pull that person back in so we can help that person to remain as well as possible. The point is, mental health, mental illness, you can recover from. We can give you the support. You can lead a good life. So I'm going to move on to psychiatric hospitals, if it's okay. So we have 3 acute psychiatric hospitals, and this is all historic. Is it right? You were on the slide, sorry. So the one before? Okay, shall I just speak to district hospitals? Okay, so let me contextualize. So we have 3 psychiatric hospitals, and they've historically all been placed in the metro, about less than 20 kilometers apart. And that's what we have, and that's how we work with it. So we see it as part of a Lentegeur catchment we talk about, a Stikland catchment, and a Valkenburg catchment, just to orientate ourselves. So the psychiatric hospitals provide various services. If you look at Lentegeur Hospital, they've got a huge amount of beds, I think up to 300, for persons with intellectual disability. And they've been there often for many years in our service. Then we have a strong acute service, which has got over 200 beds. And then we have some services for child and adolescents, which is an acute service and a therapeutic service. We also have a big forensic service at Lentegeur, about 150 beds. So they've got like 691 beds, but there are components to it. They also have outpatient services for most of those services, but they're a specialized hospital. Pretty much, Valkenburg Hospital's got a catchment that they serve, and we can be more specific about that, like Somerset Hospital refers, False Bay refers, Victoria refers to Valkenburg, as well as Grooteskier. And these services you can divide into a strong acute service, which is like 252 beds, it goes up sometimes, and the forensics, which is a very, very busy service as well. They do the observations that are referred from court when there's a crime and there's a suspicion that there might be the presence of a mental illness. The courts refer the person, and that's what Valkenburg does. Once the person has been declared a state patient, it becomes Department of Health's responsibility to provide a bed. And that service is an ever-growing service. It used to be filling up at the rate of 1 ward per year. So about 30 patients would come back, 40 patients back per year. We have seen an increase in that in the last while. So, and then they run an outpatient service, and they do all other kinds of activities to prevent relapse, like early intervention, etc. So that's Valkenburg Hospital, and then we go to Stickland Hospital also. They run a very strong acute service as well, also about just over 250 beds, and that includes the therapeutic services, which is across the hospitals. They run an opiate detox unit, which is just 10 beds, but that's often for your heroin detox, which needs inpatient care. But they also run a psychogeriatric service, both acute, but they also, like Valkenburg's forensics and other services, there's been a lot of patients we cannot discharge, so they tend to stay in hospital, and we've been forced to develop long-term beds or long-stay beds for these patients because there's nowhere to send them to. Families often not available or don't want to take the patient, and we're forced to keep that patient. Just to connect up quickly, we've opened recently a psychogeriatric ward that we're piloting through Charlene, and it's based at Alexandra Hospital. So it's in partnership with Alexandra, with Grooteskier, with Valkenburg, and we liaise closely with Stickland as well. So we're trying new things to make sure that our most vulnerable are being taken care of. Have I covered your service appropriately? And then I just want to say Alexandra Hospital, they've got 300 beds authorized, but it's not on our slide, but they for persons with intellectual disability. So I'll just move on and I'll speak to the slide in front of us. So the district hospitals. The district hospitals have previously, 17 years ago, not necessarily taken mental health acute patients, but under the Mental Health Care Acts, which was signed off in 2002, promulgated in 2004, the Act now expects district hospitals to be the portal of entry for the most acute psychiatric patient or user. So patients would present at the EC, they will be assessed. It's quite a rigorous process. 2 clinicians have to do it. There first has to be an application by often a member of the family. 2 clinicians must assess. When they made the decision, they send the application and the assessment to the head of health establishment, which would be a Mr. Swat in this case. He will look at it. If he's satisfied, he will sign off that the patient requires inpatient care for up to 72 hours. Then a 72-hour assessment is completed. If the patient is still mentally ill, a psychotic condition often is the case. Substance-induced psychosis has become an increased issue with our patients who present. They have to keep the patient, treat the patient, and try and rehabilitate, and then refer the patient to the next level, which is a psychiatric hospital. So district hospitals are extremely busy. They cannot say no. It's an acute hospital. They have to absorb those patients. So we acknowledge that. Some of them have district hospitals and regional hospitals run their own outpatient services, but in some cases they just don't have the resources to spread to that level. So just the challenges, I think, is well known that patients stay longer than we would like them to stay at a district hospital because there's also limited beds at the next level, which is the psychiatric hospital. We don't have sufficient spaces in the community for our older persons, for our children, and for people who don't have families. So we see the growing problem around homelessness, but that's just to alert how everything is so interconnected. So I think resources, we understand the pressure is huge and unrelenting. It's continued, and I'll show you now. And another issue is infrastructure. Our hospitals, even the psychiatric hospitals, were not built with this act in mind. And the profile of our patient has changed given the substance increase in our communities. So, is the next slide up? Okay, we can skip that slide. Thank you. Yeah, so just to touch on the burden of disease. So often in various disciplines, you look at the number of deaths that would suggest the burden of disease. Now, in psychiatry, you don't have that many deaths, but we do have years of life affected by the disability. So they talk about DALYs, disability adjusted life years. And all that contributes to this includes depression and anxiety and psychosis, and we are underscoring substances in this case. So that's a marker for us to see how we are affected as a community by mental illness. We just note that suicides, there's a worrying trajectory, there's an increase. April 2020 has shown that the line is going up, and we know people who have committed suicide, who have completed suicides, also would have had a mental illness, up to 90% of them. We also know that males complete suicides far more than females, but females attempt more. So they come to our service more often with this, and there's a space to intervene. I just want to note, this is just some prevalence studies done by our academic institutions, and in the Western Cape, we had the highest 12-month and lifetime prevalence of 39%. And anxieties are high at 19%, mood disorders, substance abuse, this is averages at 21%. It's also important to note what I'm talking about up until this point is an acute illness, and that's what we often call serious mental illnesses. But there's also a group of conditions called common mental illnesses where you're feeling little stress, not little stress, but it can be a little stress to more stress, where you have depression, and we're not talking about a major depression where there's psychosis. And those people often don't present for help. 1 in 4 will come. And we are saying if they come forward, if we can destigmatize mental health, we can give people the treatment they need, they will be well, productive members of society. But they're often at home, sitting quietly with their pain. And we'd like to change that. Thank you. The next slide, please. We just want to note, this is just for noting, that's just the trajectory of the suicide increase, as I've spoken about, and that is something that we take very seriously. Thank you. And the slide, just for noting, so in the top left, females, the orange color is the increase, the blue and the purple are before COVID, and then the orange color is during COVID. The numbers have gone up. And you can see it on the male side as well. So any shock to our population, any shock to a community will give rise, and it's understandable, it's intuitive, to a mental health disorder. So my slides. So the slide that you're seeing right now is all acute admissions in our province from 2018 to August 2022. And I just want you to note the red arrow, how it's going up. It's not a straight line, it's going up. There was a little bit of a downward trend in COVID wave 1, because remember our services were closed, people were at home, there were all kinds of bans, but then the trajectory has gone up. Thank you. That's just for noting. This slide is also to say an upward trajectory in our ECs, district hospital, regional hospitals, same picture. So this, and just to note, honourable members and honourable chair, that we've recently developed amazing capacity to track this information in Department of Health. We have a data system now that tells us in real time what is going on. So this information is almost brand new in the last few months and weeks, a system that now we can inform decisions far better. So that's really great. Thank you so much. Next slide please. Okay, this is for under 18-year-olds, another trajectory. If you see 2015, 2022, the numbers are going up. And this is in our district hospitals. This is not in our specialized hospitals, and it excludes under 18-year-olds going to Grooteskier, Red Cross, and Tygerberg. So this is basically regional and district hospitals. And you can see Mitchell's Plain, Khayelitsha right on top, closely followed by the other district hospitals. Thank you. Okay, this slide is on the psychiatric admissions, and 2018 to 2022, and this is 6 months data of 2022, again an upward trajectory. We don't have to focus on it, I just want to show that the trend is there. This one is interesting because this tells us about the substance-related diagnoses for admissions from January 2019 to 2022. And you can just look at the numbers. 31% Helderberg, 46% Grooteskier, I'm just jumping around. But we're averaging at psychiatric hospitals, all our admissions account for up to 23%. And that's a lot. When you get to a district hospital, it could be higher, depending on where you're at. Thank you so much. So I thought, just for us to be able to pause for a moment on the Mental Health Care Act, I did share with the House that in 2002, our legislation was signed off. In 2004, it got implemented in the province. At the time, we did not have purpose-built facilities. All new facilities going forward now will include mental health psychiatric units for assessment, which is great. But the Mental Health Care Act is an important piece of legislation. It's about the human rights of our patients. It's about the legal process of admission. You can't just say, I want to take my son and have him admitted. There's a very rigorous process to protect the client, protect the staff, but also make sure that we are not over treating people when in fact they could be discharged. So there are various processes. The user, him or herself, can appeal the process. So if I'm unhappy about being admitted as an involuntary user, remember all your rights and freedom are withdrawn because now you could be in a locked up facility, be it at a district hospital or a psychiatric hospital, you can appeal it. So the review board has, they are entrusted through the Act to investigate all these circumstances. But I think the other issue of the Mental Health Care Act, which is an important one, it's the principle of getting services as close to your home as possible. And that is why the district hospital has become so key in this new legislation. And on the other side, depending on the numbers, the district hospital could also feel pretty overwhelmed by the process, especially their EC. So just acknowledgement for that. Thank you. And that's just the process of the Act. I don't think I need to focus on that, but just to say an important thing on that Act, that slide is the red bits. So remember, you could present as mentally ill because of a physical illness, and you want to rule that out. That's why district hospitals are key when we do an admission at that level. Thank you. So in summary, it is a fact that there is an increase in the acute admissions. The burden right now does outstrip our resources that we have. We're trying to do the best with what we have. We continue to have those transformative discussions on how to do it better, how to support people. In fact, we had a conversation on Tuesday, just looking at new ways of working. It is a fact from our last survey that 1 in 4 people will seek assistance. So there are people who could get assistance and we must make space for them. And these are often people we could quite easily treat and support and rehab. It's a fact that there's a funding gap. Our HOD has acknowledged that. Substance-induced acute admissions, we just shared a lot of that with you right now. We want to say that district hospitals see, treat, and then discharge 70% plus sometimes of all patients. And it's a fact that we link them up to the community to be adherent, but that is something we can put more energy into, more resources into, so they stay out of hospital going forward. We acknowledge that the whole of government, the whole of society approach is something that we cannot ignore, and we have started to work in the process. We are connecting up with our other departments, and I'll share some of that. And shocks to our community and society like COVID does bring up some of our vulnerabilities, and we've seen that in the last slide. Thank you. So just to share very quickly, the province received additional funding, and what we used it was for strengthening of child and adolescents, psychogeriatrics, and general acute services, and also in the rural area. And it was split between metro and rural. I just want to pause quickly on child and adolescents particularly, and on psychogeriatrics. When they get admitted to a district hospital, they would be with all other patients. And what we want to prevent is we don't want the most vulnerable people to be at a district hospital for longer than they need to be. So that's why the focus has been on the adolescent and children, and also on the elderly. But also there's, I'm sure that our Minister Mbombo is well versed with this, that there's a mental health steercom that is chaired by Dr. Kluti. It came out of the wellness strategy of the Premier, and all the HODs for social development, DCAS, education, Department of the Premier are there. We started meeting at the end of February. We formed various work teams, and it's been a very exciting space. So there's been 4 areas. There's been one looking at community social mobilization, data and evidence, another area looking at evidence-based interventions, another area which we did a theory of change, and now we've come up with an implementation task team to replace the theory of change. So basically we're saying we need wellness. We need the well-being of society to be our first target. And how do we get there? What promotion strategies? How is it supported by evidence? And how do we intersectorally, departments and civil society start working together in that space? We chose 2 areas to start our work in. The first is in the Klipfontein sub-district in the metro. The other one is in the Witzenberg. In the metro, we're focusing on Gugulethu and Ayanga. We had an initial mapping exercise. We're having our second one coming up, and all departments were represented. So that was great, starting to see what our assets are, what we're each doing, how we support each other, how we refer, and how we start closing that gap. So it's early work, but that's a very exciting space. So thank you. So in conclusion, I just want to say this is our intervention framework. Mental health for you, mental health is everybody's business. As you can see, it involves the community. We cannot do this alone. The Department of Health receive cases, and we must work in this space, but we cannot do it alone. Other departments also have a role, and through this project that I just shared with you, we're starting to find those connection points. Any one of us can end up with a mental illness, and it's not just a particular group because you have psychosocial disability, but depending on your age, your socioeconomics, the social determinants that you confront, you're probably more vulnerable. We are very excited to work in the WOZA and WOGA space and to redesign going forward. Thank you so much, Honourable Chair. Just huge acknowledgement to everybody who assisted with the presentation. Thank you.
Thank you so much, Ms. Dean, for presenting to us this morning. I'm sure that the members has got quite a lot of questions emanating from the presentation, but also in all likelihood as to what our observations were during our oversight visit. I just saw that Mr. Warren Caesar also joined online. So can you kindly introduce yourself for the record?
Good morning, everyone. My name is Warren Caesar. I am the CEO at Lentegeur Psychiatric Hospital. I started in January this year. Thank you very much.
Thank you very much, Mr. Caesar, and welcome to the Standing Committee meeting this morning. Members, I will now afford you an opportunity for questions and answers. And I think after that, we've exhausted our questions and answers. We would also like to hear from the CEOs. I'm sure you would want to in terms of what challenges they encounter. Members, if you don't mind, can I have the first bite of the cherry? Fine. Thank you very much. Member Kego, when you're first in chambers, you get the first bite. So basically my question would be in accordance with slide 26, and it speaks to the interventions, or rather my question would be the interventions and the services that are available on a primary healthcare level, and you made mention of the community-based approach accordingly. I just want to make sure on slide 26 you spoke about the unmet need that 1 in 4 cases seeks assistance. Is that according to your community base? Is that how you gather that information, or is that something completely different? And then also you made the statement that the department or the facilities are ready to how can I say, to handle those cases. In our observation, what we saw, it is that the system is strained. How do you anticipate in that entire holistic approach to be able to reach out to those in the community that we don't know about, that are not currently in a facility? How do you intend to assist them in this regard, given the situation currently that the system is under pressure at this point in time? If I can just have, if it's fine with you, I will allow two questions and then you can answer them. Member Windvogel, is it fine, Member Baku, that we take Member Windvogel, we provide an opportunity, and then yourself and Member Fry and Member Keugu. Member Windvogel?
Thank you, Chairperson. Allow me first to thank the MEC and the department for well detailed and insightful presentation. I think it's an honest reflection of the situation, but I think it was a bit scant on details of proposed solutions, and I have a concern with that. The presentation raised a number of serious factors, namely the burden outstrips the resources allocation, secondly the significant funding gap and the need for 500 million for human resources and infrastructure. It also has the impact of COVID-19 on mental health. And therefore, I wish to understand the following. What are the plans to address the funding gap and shortage of resources over the MTF? And secondly, has the 500 million issue been raised with Treasury? And what is the breakdown of that amount and how much of it will be made available in the upcoming budget adjustment? Then, Chair, I am happy to hear from the ma'am who just presented. I'm not sure, I didn't capture your name, ma'am. No.
Sorry, Carol Dean.
Carol Dean, yeah. I noticed that Alexander was not listed on the list, but you covered in your presentation. But secondly, I want us to address the elephant in the room. That is shortage of beds and staff in psychiatric hospitals. Do you think that 1,827 beds across all 4 psychiatric hospitals are enough? And if not, are there plans to increase that number? Then lastly, with regards to reference made in the objective of achieving equity and mental health in mental health care, does this mean there is a inequity in mental health care? If so, what are the relevant details and how are they going to be addressed? And what is the prevalence of mental health in rural regions? And what is the percentage of mental health resources that are allocated to rural regions? Chair, then, and on slide 11, I'm taking a scope here. I can see the chairperson is looking at me, but it's not always that we get all of you guys in one room. So I'm taking that, Chair. I will move to slide 11. Mental health is a funded mandate for district hospitals. Now, if you look at KDH, the KDH management has made it clear that mental health patients are a contributing factor to the service pressure, causing, and that causes patients to sleep on floors. And part of the cause is referrals to Lentegeur Hospital. And my understanding, there's space in Lentegeur Hospital, if that you can correct me, but there's no funding available to use, because remember, we are struggling with space, with infrastructure. So I therefore wish to understand the following. Are there additional staff members at KDH to deal with the mental health patients? And then is there any additional budget to be made available during the budget adjustment to KDH? And what is the department's view on the call for KDH to be made a regional hospital? Do you think this will help address some of the challenges? I will park there. Thank you so much, Chair.
Thank you very much, Member Van Vogel. Ms. Dean, over to you.
So thank you for those questions. I'll do my best to respond. So the one in four.
Chair?
Sorry.
Minister Mbombo.
No. Can I just say something before I exit, Chair, and then I leave it with Ms. Dean to continue?
Yes, Minister, please continue.
Thank you very much. Thank you for the responses and the questions, members. Just to take into perspective, because I think the team that is there, they are in the same situation, representing health in regard to where do we get the money from. I think for them it's also about how can the members as the legislators and also as influencers, they could be able to mobilize resources on behalf. So what they are presenting is not only about, whilst they talk about acute mental health, they are painting a bad picture on what is happening in our communities. And we are, as we alluded earlier, that the bulk of those, it's not only about, they're talking about mental illness. The question about you're going to have beds, how many beds and the resources is related to mental illness. The mental health on its own public health approach, the majority of these people are outside, they are with their communities. When they're making an example of the adolescent health, which I added 30 million during my budget speech, adolescent and psychogeriatrics, the adolescent, they are staying with their parents. So what is it that that young person ended up, and they also presented that the majority is a result of the substance abuse. So what is it that from the community side, from the other sectors, not only health, make sure for the preventive side of it, so that you don't have a situation of the 12 or 14-year-olds being admitted for mental health, not only for observation, but some of them, they're already addicted to the drugs, thus them being now having substance abuse disorders, which is a mental illness now that will need a bed. So how can we contribute to that? And then on the issue again of about I think the social factors, because the main thing is the social factors. Whilst the triggers like the COVID is part of that, the current actual figures, they surpass, they are more than the pre-pandemic scenario when in regards to that. So we shouldn't be only talking about how can we mop this floor. yes, we should talk about that. How can we mop this floor through the resources, which is the staff and the beds and all of those? But how do we close the tap? Because the point is, even if the others are not diagnosed, I think, remember, Philanda asked about what about the others in the community? There are many people, some of them are us, it might be me, it might be whoever, where they will need actually to sit down and have a one-on-one conversation with a clinical psychologist, with a psychologist in the public spaces, with a social worker, whoever. Just probably, I feel like I'm in the hole, I'm in the dark. I'm not sure it's because I'm unemployed or not, but there is not that kind of a space. The only time we see them is the time when actually the horse has already bolted. Whether they go, because in the primary healthcare services, we do have like advanced site nurses, whether it's every day in some of the CHCs or it's a once a week, mostly, for example, in the clinics in the rural areas. But the question is the mental health status of a community on its own. How do we, all of us, can be able to work around that aspect? Especially like now, when I was saying that I'm in I've got load shedding. That now that even the money that is meant for services, we have to make sure that now we pump diesel in all of those generators that we have, because only as exemption is a Tigerberg, Grooteskier, and Red Cross by the city. But all other facilities, we have to take money in order to pump to make sure that the lights are on. Now, in terms of the lastly now, Chair, in terms of the shifting the resources and all of those, the funding for the mental health, there was a portion of it which was also added as part of the COVID and HIV/AIDS grant. That is part of it. But also the issue that as part of the infrastructure, now we are making sure that we have added, I think that we did present that, psychiatry units at the district hospital. Like I'm coming from Witzenberg, where I've seen the progress of the 4-bedded, in addition to their 72 hours, which is upcoming. And now that we also have appointing community psychiatrists so that they can do the outreach in the mental services, not only to focusing on the acute or those patients who are already institutionalized. That even the Western Cape government, it has made mental health as one of the priorities, in addition to the jobs, in addition to the whole of the dignity and well-being, to make sure that it becomes a transversal. And also each department should be working silos. And we are piloting it, as has been evidenced, to make sure that all of us are all under the same roof. So indeed, where we are is about, we'll never be able to get 500 million anyway, just like when we're arguing about 150 for Khayelitsha, especially with the MTEF, as we have seen that with Western Cape and Gauteng, even their equitable share is going to be reduced. But how do we make sure that we tackle the socio-economic determinants of health, which is the issue related that can be tackled outside a government system, but working with the government, because that our youngsters are even taking and also ended up being a mental health patients. That there is a high level of the psychogeriatrics is mostly about the older persons, specifically women, whom are being cared for, because it's our mothers, grandmothers, who are being cared for in the families, but it's up to where that it becomes part of the communities or the population that is under service, that now we have to take care of them through the additional resources. So there are no resources that are going to coming from, because for me, what I've asked now from the Treasury, it's about, please, we cannot be able to afford so much of the money that we have to spend on the diesels. That's a lot. And the AFDAC coming now from COVID, because some of these places, people are waiting outside long queues. How do you make sure that we have got the AFDAC for those people and there's no new money? All the money we have to roll Paul and pay Pauline, shifting around, which is we are actually going to be presenting at the next MTech to the Treasury in order to be able to shift resources. Over to you, Mr. Dean. Thank you very much. I have to exit now. Thank you.
Thank you very much for your input as well, Minister, and providing context according to the questions that was raised. You are excused. Thanks, Minister. Ms. Dean, you can please fill in if you still
Yeah,
feel
so
necessary.
thank you. So I think the Minister covered it quite comprehensively. So I just want to add that the 1 in 4 came from something called the SASH study, and I think it was done quite a while ago, but where they did this assessment, and it's often for what we call the common mental illnesses. So someone with a few symptoms, but not feeling strongly enough to come to the facility, and there is help for that. Thank you.
Thank you very much. Ms. Dean, I recognize the Honorable Baku Vos.
Yeah, I just want to check, sorry, Member Baku, first chairperson, are we allowed to ask follow-ups? Because I also noticed that some of my questions was not answered.
Sure, Member Van Vogel, please proceed with your follow-up, and then Member Baku Vos. You can proceed, Member Van Vogel.
Thank you, Fighter Member. Yeah, the question of the 500 million was not answered. And then also the issue of the space available at Lentegeer also was not answered. So I will just ask to get an answer on those two, Chair.
Thank you, Member Van Vogel. Ms. Dean.
Thank you so much. Could I defer whether it was raised with Treasury, the 500 million without Dr. Kluter? Because it's something he did to, if I get it right, the MTB PC, I think the Premier's meeting. So I will just leave that one for him, and I will definitely follow up for you. So thank you for that question. Yes, it is probably, we're doing an audit of what wards are available right now and how we could utilize it differently. So we're looking at a comprehensive service plan, as the Minister was just saying. Acute beds is one option, but we're really trying to get people into transitional care so they can get well and we can discharge them. So it's quite a comprehensive process that we're looking at. If we look at the length of stay at Kalicha, Mr. Binz is on the call, we've already seen huge improvement. So patients used to stay at Kalicha for 22 days before, they now only stay 14 days because we've already incorporated them faster to Lentegeer. We're trying to push that even more. But funding is the one thing that holds us back, even when there's a vacant ward. But we're looking at the vacant wards as part of a comprehensive service plan going forward. I hope that answers that question.
Not really. Me in a way. Here, with their own budget. And because they can't afford it anymore, they send the agreement was stopped by Lentegeer, and the patient went back to KDH. There's open space. I'm not speaking about the allocation in terms of beds for Lentegeer. There's space, there's wards. I think there's a new agreement with another NGO. So I'm speaking about that.
Thank you, Member. Ms. Dean.
Thank you, Honourable Member. So yes, sorry, so we're doing an audit of what is vacant at Lentegeer, because there are a few wards vacant at Lentegeer. Having said that, we had a problem with the storm a couple of months ago, and Alexandra needed to move a lot of their patients over to Lentegeer and took up some of those vacant spaces. So we have called for a full audit and to see how to best utilize it. And I note the question that it's not from Lentegeer's budget, but the budget will have to come from somewhere, and that question will have to defer to our HOD as well. But thank you. The noting of the vacant ward spaces is the issue. Thank you for that, Honourable Member.
You happy, Member, for now? Thank you very much, Member Baku Vos.
Thank you, Chairperson. Chairperson, through you, my first question will, let me first say, I know we note that the province had the highest 12 months and 12 months and lifetime prevalence of mental illness. In South Africa, it seems it stands on 39%, if I'm right, and with substance use disorders contributing the highest is a cause of serious concern. Now, this again emphasizes the need of an effective hold of society and government approaches. Can the department therefore outline the provincial government action plans to address this pressing concern and how much budgeted for it? And what are the causes for the high suicide deaths? What is the government intervention and how many deaths have been recorded in 2022 to date? And in slide 18 to 19, with regard to mental health presentation for emergency centers, Chairperson, due to substance use disorders, firstly, this shows that the challenges is not only health related, but other government departments need to play this role. And therefore, I want to ask what partnership exists between the various government, the department to address this challenge. I would like to know that. And is there a need for more rehabilitation centers in Khayelitsha, Mitchells Plain, and other working class communities? And what is happening in Khayelitsha that has caused such a high increased mental health presentation to the hospital? And to what extent have this contributed to the increased service pressure at KDH? My last question, Chairperson, still in slide 18 to 19, clearly indicate that the need of additional mental unit across these facilities. How many of these facilities have mental units and what are the plans to build them? And the last one now, what challenges are experienced in these hospitals and what are the current backlogs for examination? What are the plans for the additional beds and staff? Thank you very much.
Thank you very much, Member Bakufos. Member Frey.
Thank you, Chairperson. Thank you for the presentation, Ms. Lina. We appreciate it. Just 4 questions from my side. There's a concept called the revolving door syndrome, which is prevalent in our hospitals, whereby patients are treated, they come out and they're discharged, but then they fall into relapse and they come again. I understand the need, the work of the community health worker, but I'm sure that the caseload is just overwhelming for them. I'm pretty sure that the caseload is overwhelming for them. What is the plan and what is the strategy for dealing with this revolving door syndrome? And then I'd like to talk about turnover of staff. I'd like to talk about your thoughts on how to prevent turnover, the high turnover of staff in the psychiatric hospitals, not necessarily district hospitals. Then the third question is the parity of budgets across the 3 psychiatric hospitals. Are the hospitals getting the same budgets? I know the budgets are not adequate. I'm not going to ask if they're adequate or not because I know the answer is no. But is there some form of parity that we're not robbing Peter to give to Paul? You know what I'm saying? If we're not overly taxing one to help another one. And then the last question is the police, when they arrest someone with a substance and they just assume that they're taking this person as a psychiatric condition, and they just immediately give the person over to a psychiatric hospital. Surely there must be, when we talk about a whole of government approach, surely there must be a sense when the police can't do that because they're not qualified mental health practitioners. So what is the discussions with the police regarding that in the specific catchment areas per the hospital? Thank you.
Thank you very much, Member Fry. You may proceed, Ms. Dean.
Thank you, honourable members. So the revolving door, and the question is, can we load this on the community health worker? Is it just not too much? So it is a process. I was sharing with you earlier that we have this amazing data system that's in place for mental health now. We can now track, and this is the data that the department has given us access to as well, with all the changes. We can now track per area the revolving door patient who's been readmitted within 30 days, 60 days, 90 days, etc. And we've always had it, but retrospectively. Now we can have it pretty soon on our desk. And as a facility, you can see that there's a person that keeps coming back. What's going on there? Can we try and intervene? How can we do it differently? It's aspirational, a lot of it, but that's the capabilities now, if that makes sense. So we're aware of it, because if we can contain that, we will reduce the footprint to our facilities and our acute wards. Because you're right, that is one low-hanging fruit, if I can put it that way. Sorry, as I'm starting with honourable members' questions, and then I'll move. Is that okay? That I'm doing it in a different form? Okay. And then turnover of staff. Can't really comment because we generally, in my opinion, at psychiatric hospitals, we have long-staying staff. We have a facility at Lente here where there are key posts that are vacant. It's at the district hospital, like at Kalicha, that we've had a turnover of the psychiatrists, particularly there. But of course, we have now started talking about, with clinicians, how can we try and do this differently? How can we have a system of support rather than an individual person at a hospital? So it's ongoing conversations. And we met recently with key people in the room, in the Lente catchment, Mr. Caesar will know, and it was a very fruitful discussion. So we're aware of that, and we're aware that we must support our staff. Parity of budgets. What is nice in the psychiatric hospitals, the three that I mentioned, excluding Alexandra, is that the organograms are similar. So that's where I can't say that there's complete parity, but we are starting to look at the nursing ratios. We are looking at the experience versus numbers, categories. But the department on the whole has started talking about more equity resource allocation. So we do work with historic, but I think we're pretty much seemingly on a similar playing field, if I can put it that way. Police arrest of substances. I find that the police is very cautious to arrest someone if there's a suspicion of anything that's mental illness, and this is in our discussion with them, because they know it could be a civil case. So they often need to be informed by ourselves about the application process before they admit. If they bring someone to hospital, they have to fill in, if it's a mental health care user, they have to hand over the form 22 to say, when I delivered Mr. X or Miss Y, when I picked her up, there were no scars, no injuries. Now I'm delivering her, I see that there's a red mark or a scar or a knock, and this may have happened in the time that she was transported. So the Act is very specific about that. And we do meet with them in our local areas now in this mapping process that I referred to earlier. If that's satisfactory, I want to move on to the honourable member on the other side. 39%, it's high. Prevalence for the Western Cape. I can't give you specifics for rural. I can try and find out and respond to that. Substances, yes, it is. And I'm so pleased that our department colleagues are here from Social Development, because they're the custodians of the Prevention, Treatment and Substance Act. That doesn't mean that we don't have an important role to play as health and other departments. And we have in the past worked quite nicely together. We do everything that's medical, we screen, and then we refer. And I'm sure there still is a directory of facilities close by, like outpatients that are licensed. I'm not sure what the situation is, but it will be nice to hear from them. We have on our to-do list as a Department of Health, we've got an internal huddle with our COO, Dr. Karim. We're discussing substances because we've got a new drug master plan that has come down from national, and our role specifically in that, we just want to confirm and refresh that. I hope that satisfies that. What's happening in culture? I think we need our collective wisdom. We need to understand what the social determinants are. We can presuppose, but I would imagine the environment, joblessness, frustration, our youth. So all those things could contribute and probably do contribute. But it's something that we need to collectively put our minds to in the WARSA and WARGA space. And that's why it's so important. The backlog, can I get back to you? Because that is something that we'll look at. I do know that the new hospitals coming on board that we've already put plans in place for is the Balhar Regional Hospital, the Klipfontein. There are units that are coming on board for, I don't know the time frames, but New Somerset, Kalicha. I know that your unit probably needs expansion at some point, but you have the benefit of Lente here being close by. So where there aren't infrastructure plans, hospitals are trying to do the best they can with what they have and converting spaces. I hope I've covered your questions. Thank you, Honourable Member.
Member Bakufos, do you have any follow-ups?
I think the follow-up question that I would like to as I asked the question now, can they involve before there was a cry for a community that social development they don't give them here. So I would like to see
Thank you very much, Member Bakufos. I'm sure as we will hear from the Social Development Department, that will broaden our perspective in terms of what their contribution is towards, rightfully said so. Member Klego, I assume there's no other follow-ups from Member Fries just stepped out. Member Klego, can I quickly just ask before I hand over to you, Member Bakufos made mention of the collaborative approach in terms of other departments, and I think that also latches on very importantly to the budget. You've made mention, did you say there's a new drug master plan? Is the drug master plan? Did I hear you correctly?
Yes, the 2022 one just came out, was just issued. Yeah.
Okay, you made mention of that, but also the act in itself. And I think some of us perhaps have not read into it page by page, but one would like to understand in terms of what is on paper, not just how that transpires in your capacity itself, but what is expected from legislative side, budgetary wise. Is that possible for the department to implement in this day and age? And also, does our budget from the national department, does it account for all those mandates, or are the unfunded mandates that the department provide for them in this regard? Member might mention, for example, the police picking someone up. Is it not in some cases their responsibility to do their job, but the easiest way out is to refer those cases to the health department? We've also heard about the forensic interstate cases, which people, it's not a short period of time that people occupy the space, the bed space, the resources, the departmental budget. Is there not an obligation to those state departments to alleviate or to contribute in order to relieve the pressure from the health department And then I would also just, if you can just perhaps give insight, as we now are currently in the process of looking at the NHI as well, would the funding and the mandates be contained within that proposed piece of legislation? How will that impact on mental health, not just the Western Cape, but all provinces in the country as well? Thank you very much. Member Keugel?
No, thanks, Chair. Mine would be on page 9 or slide 9, which talks to the recognized NPOs that we are working with. Now, if we, as public representatives, working with our constituencies, some of these, especially the dealing with patients that are still outside that need to still be referred to such institutions, if we would be able to know the number of the NPOs that you're working with, especially those that are funded, you might not have a direct answer now, but if we could be able to be furnished with that, so that we would assist in terms of referrals, so that we don't, especially from rural areas, we don't find ourselves having to overload you or the institutions here in the metro, if we would know from the rural, in particular from the rural areas. And then the second question is on the issue of 3 institutions, psychiatric hospitals, that are all situated around the metro, and of which, whilst we're doing the oversight visits to different hospitals, including the likes of in the Overberg, we have noted that they have improvised in dealing with the mental patients, and of which one of the key issues that they've raised was that their staff was not coping to deal with that, because initially they were not trained to deal with mental illness, what we call it, patients. So now what we want to understand, coupled with the fact that you have raised the issue of budget, resources and staffing, and then the members have raised here that the collaborative approach between departments. And we note that there are a number of Department of Public Works institutions that were previously utilized and they are not utilized. They are standing as white elephants. For example, in the Overberg region, you would find that Swellendam prison that used to belong, that still belongs to Department of Public Works National, is standing as a white elephant there, and of which it could ease the pressure that is enjoyed by the metro in terms of facilities. And also in the likes of George, of which that might assist the Garden Route and as well as the Central Karoo, has got the Department of Public Works Provincial, the former York High School hostel. We've recently or previously requested it to be utilized by what we call it students in the South Cape College. But if you check the need in terms of priorities, the Department of Public Works has got a number of institutions that are no longer utilized. So in terms of trying to ease, because you don't have to build institutions from afresh, whilst there are a number of buildings that are available in terms of that. And then the last part is the issue of the deaths that have increased. Note that close to 2,188 between just 2019 and 2022, which is a high number. One of the key issues, which also relate to what I've just recently raised, when you have got patients that are confined, or any individuals, even if they are not patients, having worked for 13 years in the Department of Correctional Services, we have had a number of suicide attempts due to lack of visits. And we note that during the COVID period, the lockdown, the number have increased due to that because there was no movement. So with patients, it's a serious challenge. So now, how can we be able, is there a preventative measure now that you have noted that the suicides are literally increasing? Are there any preventative measures to ensure that suicides are declining? Thank you very much.
Thank you very much, Member Tergo. I think I'm going to forward the department to answer the two, then we'll come back to you, Member Van Vogel. Ms. Dean.
Thank you so much. Let me just see the collaborative approach around substances, particularly, Honourable Chair, and has it got budget implications? I think that was the question from myself. If we work together, well, this is something that we as health, we do the medical side of substances. The custodian is social development. So can I defer the question about the Act to them and the specifics? So if there's a medical detox that is needed, they would enter primary health care. We've got very clear protocols in place, primary health care. If it's an inpatient intervention required, it would be a district hospital. If it's the opiate, it would go to Stickland, like for heroin. So we're very clear in health what we do. There's always been a great connection between the two departments, and I would refer, I must admit, COVID has probably interrupted a lot of that. And part of us putting it on the health agenda again, not again, but putting it on the agenda, it was supposed to be in September, we've moved it to October, is to have a high-level discussion with our Chief Operating Officer, Dr. Karim, and then all the managers are there, just to be clear again and refresh that those protocols are still appropriate, etc. So if I'm understanding correctly, if it's still the case, social development fund or subsidize or support the rehabilitation centres. So if I may just defer that to our colleagues on that side, Mr. Gigaba, if that's okay. NHI funding, I personally don't have enough information. There's been various discussions, but I don't have enough information, so I can defer this to Dr. Kluti and get back to you, because that's an important question as well. I hope I've satisfied that. And over to the Honourable Member. NPO working together, thank you so much. I think that is what we want in the collaborative community space, to talk about what is needed for our population and community. If there are NPOs that need support, if there are discussions about how to strengthen, we've got a list of NPOs that we fund or partly fund. And a lot of the funding sometimes happens between our two departments, social development and ourselves. So we've got a list and we can respond with that. And it's become a big focus in our department, community mental health. So that's great. So thank you for that. Vacant building spaces. Again, thank you for noting that. I don't have any knowledge about the Overberg specifically and the George area, but I think that's the kind of discussion we're taking up in our community mental health space. How can we support what's available? So I think all resources are extremely important. We'll note that, we'll take it up with our directors and respond in writing. Suicides, absolutely. I think it's worrying for all of us. The mental health steer comp that was just recently formed is starting to bring departments together in the most local space. We've got two pilots I refer to, Witzenberg, and the one in the Klipfontein sub-district. So we're focusing on, in the sub-district here, in Klipfontein, just on Nyanga and Gugulethu, and we're starting to look at what is education doing, what are the gaps, what is health doing, what are the gaps, how do we interconnect? So that's going to be nice to follow that progress of that work, where all departments come together. So I think it's a start, because this is a worrying statistic, especially for our youth. So thank you for that.
You happy, Member Tergo? Thank you very much, Ms. Dean. Just for me to be absolutely sure in terms of your reference to the Social Development Department now, I understand that you do make the distinction in terms of roles and responsibilities and where the department fit in. But I'm trying to establish, based on what we as a committee have observed, is that you being the custodians of national legislation and expected to implement, those that are expected of you, do you, in your view, or of course in your space, do you have or do you receive adequate budget to do what is expected of you when it comes to that legislation as it currently is? And also, as I said, those mandates that you carry, whether it's formal, I don't want to say formal or informal, but those patients that is in your care, for example, should you not receive budget from somewhere to assist and to make sure that the pressures from the Western Cape Health Department is alleviated in that sense? And also, is the one question that you said you refer to the HOD, is that the one of the NHI? Sure.
Thank you so much for that question. Absolutely right. As I kept illustrating that the increase of substance-induced psychoses is a huge concern, and it is close to almost 30% of patients we see, definitely 23% in our area as psychiatric hospitals. If we could prevent that, of course, we have more space for other patients. We are already claiming, as we said so often, that our resources and the burden isn't matching up. So I think that response is in the affirmative. Thank you.
Thank you very much, Ms. Dean. Member Van Vogel?
Thank you so much, Chairman. Last two questions, or let's say on page 27 on the slide. I just need the department to tell us more about the mental health mapping pilot. What are the terms of reference? And when is it started, and when will it be rolled out to other communities? And then lastly, Chair, ek probeer verstaan, of ek wil graag weet die personeel, het julle statistieke of sê hoeveel personeel het mental health problems? And who do you, in terms of your service provider, is it only metropolitan? The reason why I'm asking is we are getting negative feedback in terms of metropolitan. People are not, staff are not using them actually anymore. So I just want to check, are you only using metropolitan? Because there's staff that do have problems, but they are not using metropolitan. Thank you, Chair.
Thank you, Member Van Vogel. Ms. Dean?
Thank you so much. Let me start with the last question. To my knowledge, it's only Metropolitan. That's our service provider. I used to know the statistic of what was the incident of staff issues. I don't know it offhand, so I'm sorry about that. Can I respond in writing to that as well? But I can imagine that not all staff are presenting when they probably need the support, because we're part of a bigger population, the same as the communities, we're from the community. So let me get that, because I think it's an important statistic, sorry. And then about the mapping, thank you for asking as well. So this HOD SteerCom started at the end of February. We meet every 2 weeks. So Dr. Klute, he chairs it, Dr. McDonald sits on it, and we have Department of Culture, Sport, Art and Sport, and we have Department of the Premier, who provides the governance for that space. We have education there as well, and we have a few other departments, sorry. And we then have the 4 subcommittees, as I shared. There's one to look at interventions, evidence-based interventions. So we have Prof. Siddharth, who oversees that, and we work with a lot of the universities on that space. We have one to look at all the data from all departments, and it includes exactly what you asked about staff as well, because staff are as important as the clients we see in our facilities, and they need to be as strong as possible to deal with what they deal with. So they include it in that, in the process. So when we look at wellness, we want to include everyone in the community, including our staffing needs, broader society. Sorry, you were asking. And then I was just sharing that there's also the community mobilization approach, just trying to understand what that looks like. And we report every second week to our HODs on this. So it's quite a focused approach, the mental health SteerCom. And there's an implementation task team. And it's in the implementation task team that we did a theory of change, And then out of that was that we need to come up with a wellness strategy. So working with a wellness strategy, we felt that before we get into what we should do, we should first know what is currently available. So that's what we're mapping right now. And we started with provincial government departments, then we'll go to our faith-based, our NPOs, community. So it's been a process. So it's really in its infancy. We should provide a report that gives us firm direction by the end of October. So Dr. Kluti and the HODs will get a report by the end of October on our real progress in that space. I hope that satisfies that. Thank you so much.
You covered Member Van Vogel. Members, I do not see any further hands, and I think for the sake of time, I know Member Barkhoff will have it at me for mentioning time, but I think we utilized our time quite effectively at this point in time. We could raise our questions. We had opportunity for follow-up questions as well. But we do have the CEOs of the various institutions here as well. And thank you for your indulgence at the various facilities when we rocked up there unannounced. But that is something that the committee in itself really felt strongly about, that we need to experience the real situation and having this engagement. And as we've resolved already, we're going to have a broader and a bigger extension of the specific group, because us as legislatures, we have the means and the opportunity to influence legislation that you guys are required to implement. So I'm not going to give it all away at this point in time, but that is what we intend to do as to how we can approach other spheres going forward to make sure that the legislation that might hamper or impact, whether it's budget or your rollout of the work, that the very important work that you need to do, how we as legislatures can influence that pieces of legislation. I will now afford you the opportunity to give us some input from your side, anything that you would want the committee from our oversight perspective that you would want us to indulge with, something perhaps that Ms. Dean left out or the Minister, you are most welcome to do so at this point. And after that, Ms. Kivitz, I will afford you the opportunity for your questions as well.
Good morning, everybody. I think Ms. Dean presented quite well, and from the questions that came out, I think we are quite well covered. And as a CEO from a hospital, the only thing that I would like to emphasize is that we need to prevent people from coming in, and we need to be enabled to discharge patients. And what would that make that possible? It's not only the intervention to the individual, but also the intervention to the whole family, the whole community, and the whole of society. And that is really our plea, because yes, we can have more beds and we can have more staff, but we will just not be able to discharge people. So for me as a CEO, my biggest request is, can this legislator support us, this committee supporting us in getting appropriate preventative services where all departments work together to support people and maintaining and preventing mental illness, and making sure we have appropriate prevention and rehabilitation services in the community, but also when there is a safety net needed, that we are able to discharge people. What affects me, our hospital, is what we've said is the Mental Health Care Act, but also the Criminal Procedure Act, where it makes it very difficult for us to discharge state patients due to the stringent criteria. And as what Ms. Dean have said, that we have, over the past years, the numbers that gets admitted is almost a new ward. We mid-2022, we passed what we've been admitted already over a year, per year in historical. And the question then also comes back to what is the rehabilitation services for state patients, and how does all the other departments, Department of Justice, also contribute to supporting active rehabilitation of those patients? Thank you.
Thank you very much. Amen.
Thank you very much for the opportunity. I think I agree with my colleague. Mr. Steen has presented our information, I think, accurately as such. But just from Stikland's side specifically, I think one of our biggest challenges at the end of the day is that we deal with the provincial geriatric service as such. And the complexity around that specifically is the protection in terms of assets as such, and the vulnerability of the geriatric patient, and our connectivity in terms of Department of Justice specifically. So from Stikland's side, we need to start facilitating processes, for example, in terms of curator applications for our patients before we can discharge them, which means that other than providing a health service, we are basically providing a service that can be done in the community, but because the person is vulnerable as such and the person does not have placement in the community, the person remains in our service. And because we have to wait for justice in terms of the curatorship application process, which is not prioritized by the Department of Justice as such, we end up keeping patients so much longer in our service. So often I think what's important is how can this committee, for example, advocate with regards to that specifically for us? Then the other issue is licensed registered facilities. We cannot discharge our patients to facilities that are not licensed and registered. And we understand the need in terms of that. We understand the responsibility in terms of making sure people receive appropriate care in the community. We do not want a life Isidameni situation in the Western Cape as such. But then we need to start increasing those facilities as well, because there are too few of them. We have to wait for someone to pass away in a facility before we can move another person into that vacant space, which means then that the district will complain. They will complain and they will have patients sleeping on the floor, etc., and they will feel frustrated with us. But what do we do at the end of the day? Where do we send someone who today has no place to go to as such, and who there are no facilities in the community for that person? Do we just show you the gate? Do we just say there's the gate, you need to go wherever, you know? So those are the challenges that we deal with, is the humane issues in terms of dealing with the psychiatric patient, which are not the same in terms of other health fields specifically. The psychiatric patient has the vulnerability of not always having the capacity to be able to make the most important life decisions, etc. So those aspects need to be looked at specifically. And then also, obviously, again, the issue of health services having a huge responsibility with regards to taking care of people beyond the health mandate. We're supposed to treat you, and once you are well enough, we should be able to discharge you. We cannot do that as such. And I think often communities don't understand that, and also the stigma that goes with it. Yes, there are some facilities out in communities. The gentleman spoke about buildings that are vacant, etc., etc. But there's also buildings that have space for persons with psychiatric conditions, but because of stigma, we can't even access those facilities as such. So those are the things that we need to collaborate around, and we need to look at how do we improve on that, because that will help us a lot in terms of service delivery. Thank you very much.
Thank you so much.
Thank you for the opportunity, honorable members. So I'm from the Mitchells Plain District Hospital, and we are in the Lentegeur catchment area together with Kailicha District Hospital. In same like them, receiving lots of acute admissions through our emergency center. I know that my colleague, Mr. David Binzer, also has briefed the committee before, so we can just take that a bit in mind with, you know, what I have to add. So we've already covered the services that the district hospital does according to the Mental Health Care Act. I also just want to add that, I mean, when it does come to high-risk patients, vulnerable patients, we do fast-track those patients so that they don't spend too much time in our over-capacitated environments, and through collaboration with our colleagues at Lentegeur, we move them through the system fast to reduce that risk. And when it comes to the drug-induced psychosis that we see, we know that often it will take a bit longer, but I mean, these are our patients in our communities. We know that that is not what a tertiary hospital is there to see. They're there to see the more clinical psychosis, you know, the psychiatry, schizophrenia, mood disorders, and so on. So we will sometimes take a bit longer detoxing a drug-induced psychosis patient, and then transfer them to the primary healthcare and hopefully link them up with facilities, DSD in our community. So our situation analysis at Mitchell's Plain, similar to Kailicha, although we have had a purpose-built 30-bedded psychiatric observational unit built 2014. And then 2016, due to the space already being confined, we split the males and the females, and collaborations with Lentegeur, we've got a ward there where we keep then the females separately. In that way, increasing our numbers, bed numbers for mental health care by extra 15. But like I say, that takes extra resources then to look after, so we need to get extra nurses for that. However, the doctors, their numbers stayed the same. They were able to manage that. So that's where our budget, becomes affected. And I think I just want to link with what the minister said earlier, just to make it real for you. I signed over the last 2 months since level 6 came into effect. I think we've got a 10,000 liter diesel tank, and we also service clinics in our area. The first order to fill the tank was 234,000, and in the week, last week or this week, I signed another order of 240,000 to fill that tank. So that's almost 500,000 rand spent in the last 2-3 months just on diesel, when we've got other, needs in our area. Just to put that into context a bit for you, and then, as we said, both our male and female mental health wards are above occupancy, above 100%, and the length of stay, initially was above 15 days, but we have improved, and I'll tell you some of the things we've done to improve that. Before we hand over to the DSD, some of the contributing factors to our high occupancy in the mental health space. Obviously, we've got our chronic diseases, we've got our trauma as well to consider in a district hospital, which is also high. But mental health, social determinants within the Mitchell's Plain community, as we've spoken about, is the drug problem. Drug abuse, conservatively 25 to 30% of patients that come into our EC is due to drug-related, drug-induced psychosis. We've got alcohol abuse, contributes to violence, the GBV, the familial, family, household breakdowns. That affects mental health and well-being across the board. In a lot of ways, our emergency center is a mirror to what is happening in our communities. It reflects and plays out in that space. Then we've got the gangs, gang violence. We've got unemployment and our socio-economic factors, which plays out in the mental health spaces a lot. Our backyard dwellers, homelessness. So that's our housing factors. We spoke about, because of these factors, we discharge patients back into that same community, which makes it difficult for them. So you've got poor adherence to medicine. We've got appointments being made. They don't, pitch up to those appointments, which makes then that adherence to that care plan that was prescribed on discharge doesn't happen. Creates that revolving door effect. And then, there could, as we've mentioned earlier, there could be more rehabilitation facilities and safe spaces in the communities, which would definitely improve mental health factors. We spoke about the revolving door. We spoke about SAPS, and sometimes we use the Mental Health Care Act to kind of cover criminal activities. I mean, even families do that, not just SAPS. Your family member, your child, your adolescent drug users, stealing, wreaking havoc at home, actually criminal activities, then you bring them to the hospital, easy, as a drug-induced psychosis under the Healthcare Act, covering those other atrocities happening. And one thing that is very prevalent is that this is affecting much more males than females. The male ward is about 3 to 1. There's 3 times more males than females. If there's 15 females, then there's 45 males in that space. So that's the contributing factors. And then the risks, obviously, is the patient safety, the staff safety, because you don't know what type of patients are in there. Well, we've spoken about those risks. And then same as my colleague David Burns at KDH, I just want to talk now about some of the success factors, because this has been a high priority for all of us in the Lentegeur corridor. We've been having collaborative meetings quite often. Our doctors meet as a huddle Mondays, Wednesdays, and Fridays midday just to see what the pressures are, where we can move patients around. So I know in Kailicha they've reduced the average length of stays and the bed occupancy rates, and similar at Mitchell's Plain, where we're currently sitting now. We've reduced that days to just about 10 days or under 10 days, which is manageable for us. Our occupancy has come down from about 150% to an average about 100%. So we're using that. So that means, you know, you don't need all that extra resources, extra staff and patients having to sleep on mattresses and those type of things. So we've, most of those successes have come through, you know, some trying some new innovative measures, treating quicker, faster intervention plans, and then this plans we now on our collaborative platform trying to share those learnings to move patients faster, and then upstream for us working together with Lentegeur Hospital means that we can. They are accepting on average more patients this year than they were last year per month, as well as our more serious cases, they can move faster. And then discharging, we discharge from all the patients we see in our ECs a month, about 70% of them get discharged back in the communities after the 72-hour observation period or detox period. And we've also been linking them with the primary healthcare. And that is a project that we're trying to do better, just trying to follow up that patient that we discharged and we gave them the appointment for that, did they actually come there, so that we can make sure and maybe catch that person before they are revolving door patient. So these are the type of things that we've been putting in place to try and move that system through a bit better. And the successes really has been coming through in collaboration with not only myself working in my space at Mitchell's Plain District, but working together with Lentegeur and Kailicha and sharing that burden. So if we can extend that further with our colleagues in the DSD and see what else they can do, is because it's what Ms. Goliath has said, if we can just reduce the amount of patients coming back, we can start seeing those patients with that real mental health need, with the schizophrenia, the bipolar mood disorder, those things that's not self-induced or society-induced factors that are bringing them to our ECs, then we'd start, you know, seeing some improvement in this space. And the answer is not always just getting more beds, but if we can get that interventions right in the communities, we could, you know, stem the flow into our emergency centers and into our system. I think that encompasses from Mitchell's Plain side. And once again, want to thank you for shining the spotlight on this area, because if it goes unchecked, we will, you know, be tipping the scales, which in many ways, especially with my colleagues in Kailicha, you can see that tip is, the burden is quite high there. Thank you, members.
Thank you so much. I will forward the opportunity for Mr. Caesar. Mr. Caesar, are you there?
Yes, I am. Thank you very much for the opportunity. I'll probably start off by echoing what my colleagues have said, and thank you for the presentations and questions. We were at the Public Health Administration Congress a week ago, and I think one thing that jumped out at me is that Act number 70 of 2008 still speaks to substance abuse. And I just mentioned it, you know, to our recovery team last week, to say that's probably where we need to change, start with the change and look at our acts, because the word abuse is what starts with the stigma in our community. And if the standing committee is privileged to lobby to have that act move from Substance Abuse Act to Substance Use Disorders, then it might start with a big difference. A simple word change can make quite a bit. In terms of responding to our mental health challenges, I always use the analogy of our N2, and we've built so many lanes over the last decade on the N2, but if you travel to Cape Town from the Somerset West Side, you still find yourself, backed up in traffic. And yes, that's not the answer, for or the only answer. More beds, more staff, but it's about what parts of our system do we need to look at. Mr. Swartz made mention about how we are collaborating now. And yes, we all have taken this mental health space in the Lentige catchment area. We've taken the responsibility to zoom in on our own spaces and say, hey, what can we do differently? Lentige as an institution and our team had to start recognizing that Mitchells Plain Hospital, Khayelitsha District Hospital, Hottentots Holland, as well as the rural space are our clients. And if they are our clients, we need to respond to their need, because those hospitals and the emergency centers respond to the community need. And we then indirectly respond to the community. And so we can continue our curative and rehabilitative processes. But I think it's important for us to understand that we need to look at the upstream factors. What are the causal factors? Why are our clients, why is our community, why is our youth, why is our adults coming to our emergency centers? And data tells us a pretty good picture. And I want to maybe pause on the revolving door, because that was one of the questions. And yes, we have a revolving door, and 30% of our clients are coming back within 30 days, 60 and 90 days. And 80% of that portion that's coming back to us is related to substance use disorders. So what can we do as society to assist with the substance use in our community? How can we stem that? From a health perspective, what we are trying to do now is saying, or we're speaking about, is to have a mental health dots, like we had with the TB dots. And we use our community-based workers. Example, in Mitchells Plain, we have over 700, as well as in Khayelitsha, we have over 700. Can we capacitate our community-based workers to say that you do mental health dots, and when a client has not been compliant with the medication, immediately on that day, we take action by referring them back to the clinic or making contact with the mental health nurse at the clinic to start an intervention. If we get that right at the lowest levels, then we will not have such overcrowded emergency centers, etc. If we take that 30% revolving door or 80% drug-induced psychosis within a 30% revolving door, it can bring quite a bit of relief. So I'm happy that we have leaders in the space that's open to talk, to think, to brainstorm, and bring about solutions within the health sector. But if we can just get our other role players on board to do the same, I think having a committed response from all of us within the government sector, and we can do justice to the communities out there. Ultimately, we exist for our people, and our true directors in the space is our people in the community. So thank you very much for the opportunity, and we look forward to any further engagements with the standing committee, and to discuss challenges as well as solutions and improve the results. Thank you so much.
Thank you so much, Mr. Caesar, for your input as well. I just needed some clarity, sir, from your side. You made mention of amendments to the Substance Abuse Act for it to be amended to the Substance Use Disorder. How will this impact on mental health?
So there's been quite a bit of work done from the psychology fraternity, and the simple terminology of changing abuse, the word abuse, to use, just takes away that stigma. And we know whenever there's stigma, people are not going to seek help. And when we don't seek help, we go further down this dark rabbit hole, and then only present in the Department of Health once we have some form of incident. So that terminology change understands that as humans and people, we can seek help and assistance because it's a use challenge and not this abuse challenge that shies people away from seeking help. Yeah, thank you.
Thank you so much, Mr. Caesar, for providing clarity and input on that statement. Ms. Kivitz, I'm going to hand over to you.
Thank you, Honourable Chairperson. I have a few questions, as this is a topic very close to my heart, and I've been personally involved in a situation. So, the department's focus on wellness. We know there's been a name change, that will possibly be a discussion. But if we cannot really identify mental health in the workspace where people go for treatment. And why I'm saying that is that a patient presented at a local facility, but the person receiving the patient were not well. And the chaos that broke out was, I think, something that could have been prevented if we identify what we mean with wellness in the workplace. So I think there's a clear indication that mental health in the workplace within the Department of Health is a very serious issue, and it needs to be collectively addressed, because if we want to make sure that we address mental health within the community space, because the organizations that was trained, have their training been amended, upskilled? Because the home-based care training that was given, that I'm aware of back in 2003, 2004 was the last real home-based care training through the Department of Health. Has mental health been a secured part of that training? Because we have the Mental Health Act, which is very clear on community-based mental health. However, community-based members are not really trained in mental health awareness. Just on Monday, I had a community organization asking me for literacy on mental health issues. And when I called, we were referred by the department to a sub-district, I don't even think the information I got is what the community needed. So I do believe that if we want to co-create knowledge and be collaborators around mental health, we need to make sure that we're all on the same page moving forward. Whether it's the Mental Health Act, the implementation of the Act, the guidelines around the Act, and all community-based service organizations fully equipped to identify the need around mental health. Substance abuse, I think the Department of Social Development is here, so that I'm going to leave to that space. But that is the one thing. Then, when community members represent at the facility for appointments, I hope it has changed at the primary healthcare level, that there is one mental health nurse for 3 different health facilities. Can it be right? I'm asking the portfolio committee and the department, can it be right that you have 30 patients awaiting to see the psychiatric sister, and at another facility there's an incident, and then that patient must be either sent home or be sent to a next level of care facility? And then on page I wrote my things down so I don't forget. On page, no, there's no number on this page, but it's after page 21, the rural district clinics. It's Paul, Worcester, and George. So Paul possibly is the catchment area for the West Coast. Now, because there's no facility mentioned for the West Coast, and we know Paul is the drainage area for the West Coast. So how serious are we in addressing mental health on the West Coast? Do Vredenburg or Vredendal Hospital have space to take up people that come in with mental disorder, or are they referred from those facilities to Paul Hospital? Then there was the addressing of the master drug plan. Are we at a district drug plan or a provincial drug plan? Because I know our last discussion around the master drug plan with the previous round was that we didn't really complete the drug plan at a local level. And I think if we collectively want to address mental health issues, we need to be serious of how we implement, because it's good to have the thing, but the implementation thereof are always a challenge. And can we look at how we implement the drug plan at a local level? And I think that concludes my questions. Thank you.
Thank you so much, Ms. Kivitz. Ms. Dean?
Thank you so much. My apology for having left the room. Thank you for the question on the community health workers. I can follow up and find out what the formal training has been for the community health workers. I do know increasingly they have been taking on mental health care patients, loads, and I would imagine it's come with some kind of training. I speak under correction, and Mr. Caesar's on the call, but my colleague worked with Lenta here, particularly with the supervisor, mental health care workers in the area, and handing over clients so that it wasn't just an open space. But I can find out, because I think it's an important issue, the literacy particularly. So thank you for that question. The hospitals referred to are for the rural hospital. When I spoke about the strengthening on the slide, it was for the regional hospitals. So George Hospital had, I think, 10 beds, and they're trying to push it up to almost double that amount. So the more they can contain the acute patient in George, as an example, less patients need to come through to Falkenberg. And they've got a full multidisciplinary team. So sorry if it was miscommunicated, but the point about rural services, I think, came up, and we will respond. I think the Honourable Member is raising an important point about the dedicated mental health care nurse at the facilities. To my knowledge, we should have at least one mental health nurse per CHC, and the mental health nurse should only see the most complex cases. And there is a process around that, because there are lots of complex cases, but also some cases can be devolved. And that's something that we must attend to. So I think over the years, there's been accumulation, and we probably do need more resources. But having said that, we need to create space for the generalists to see mental health far more. So I do acknowledge the point. So thank you. I hope I've covered that. I hope I've covered all the questions. Thank you.
I see Ms. Kivitz nodding. Ladies and gentlemen, I think we're going to take a short body break, and then afterwards we'll have the Social Development Department present to us and members posing their questions. But members, if it's in order with you, I think the purpose of this exercise, and especially why we had a joint conversation this morning, is to have that interaction as to, for us as a committee, to better understand as to what your roles and your functions are, what your budgetary limitations in terms of both departments, but where you think social development should latch on in order to relieve your pressures and your burden at the end of the day. So we would want you to, if the health department is still present at the time, that if there's something from social development that you feel that you wish to elaborate on or wish to bring under the standing committee's attention, you are most welcome to do so. Is that in order with you, ma'am? So we'll take a break now from, it's almost 11:05, and we'll be back at 11:15. Mr. Member Bakofus, we just need to be cautious of time. So yes, tea break at the back. You're most welcome to have a cup. Thank you. resume with our session and immediately give over to the Social Development Department to take us through their presentation. Thank you.
Thank you. Good day, honorable members. Perhaps by way of framing the presentation, let me start with what the purpose of the Chief Directorate of Restorative Services is about. It provides integrated developmental social crime prevention and anti-substance abuse services to most vulnerable in partnership with stakeholders and civil society organizations. Well, that anti-substance abuse is from the Act. I'm mindful of what was said by the colleague from Health. The Act has been under consideration for amendment and in our view is unduly delayed. And it impacts service delivery in a whole range of areas. Relating, for example, the reality that the unregistered inpatient substance facilities, they are in the majority, contrary to the registered one. And it has got a whole range of implications about that. I was just mentioning that in passing. Secondly, I think that it is important to underscore that we are dealing with the most vulnerable. As it will be indicated in the presentation, constraints related to that. And the fact that we are providing integrated developmental services, I think that now we need to reflect on that, the implications of that, because all those areas relating to prevention, they are developmental or supposed to be developmental in nature, and the resources related to that. But this is not the reality. And it's also important to say that guiding us in this implementation is the ecological system theory. That is the bedrock of training social workers, that theory. It says that nothing should be seen in isolation. It should be seen in context, and it should be seen in an integrated way. So your family, your individual, your family, your community, and the society at large. All those things have got implications. And relevant for the presentation today are the two values that are central in our work. And it's also important to indicate that the provincial government has embarked in what it calls a cultural journey on core values. But the relevant ones is care and responsiveness, because we're dealing with the most vulnerable. Let me put a caveat to that, to suggest is that the austerity measures that have been rolled out for some time now, they are in a sense a break to what is expected by policy to be implemented. So I want honorable members to bear that in mind, because it has got huge implications, the austerity measures, because it means that what we are expected to address as developmental challenges, the budget is reduced, is cut. The casualty of that process in the year under review, or that is this current financial year, was the substance abuse program. But we're not that now. I'm just indicating, to frame the presentation. Now, as social development, we use the integrated service delivery model, which means that we look at awareness and early and prevention. We look at early intervention. We look at statutory work, and we look at reintegration and aftercare services. Now, I need to underscore at this point that when finance colleagues appear before the Treasury and they're confronted with austerity measures, what do? They say that we will put emphasis and priority on statutory work. So whatever that is not gathered by legislation is just gathered by policy, suffers the first casualty, becomes the first casualty. That is the reality. Now let me move now to the actual presentation, that it will cover social crime prevention and support, victim empowerment services in Khayelitsha and Mitchell's Plain, and it will cover substance abuse and facilities. The first one we're trying with one is that in the presentation, now these communities we're dealing with, if you are dealing with Mitchell's Plain and we are dealing with Khayelitsha, we are dealing with the most populated areas in the province. That's number one. And then we are dealing with areas that are, in a way, if you want these stresses, collectively we call these issues social ills. Perhaps to put us to be on the same page, let me hasten to point out that we are with health, the Department of Health, in the Victim Empowerment Forum. We are guided in the main by the statistics that are generated by health in their health system, and then also by statistics from SARS, right? And we are also with health in the anti-gang priority committee of Prof Joints, who are with health. So we work together with health in a number of areas, and then we have certain projects we are there in the pipeline to pilot. Right. When I get to this, it's also important to indicate that the two areas, they're in the priority areas in terms of crime of SARS. I'll get more when I get to that. Now, I'm emphasizing this point because both communities, they've got significant numbers of unemployment. They lack resources, right? And the resources, they've got the implications for people when they make movements in terms of accessing services in these areas. If I may just illustrate the point, some of the services, they're not necessarily directly in the area. Some of it is they have to travel to some of the places. Now, because these are densely populated areas and people in the backyard, inevitably, when it comes to these facilities of accessing services, they face the reality of long queues, right? And these are the vulnerable people with no resources. The issue of substance abuse that led to mental health challenges, in fact, in my view, I may be wrong. You see the mental health issues in terms of public consciousness, that is awareness, they are not elevated to the same level, for example, as HIV/AIDS. And this now comes directly into the issue of stigma. In other words, you can actually, even if you are working in communities, we can actually say, no, this one is not normal, this one is not okay. But it's not a question whether it's accessing services or not, but this is what you can see. And then if you are just working, that is in the communities, in this distressed communities, we can actually see these things, this is the situation. So I'm saying that information on mental health issues, whether it is generated from South Africa, from where, is I would say that in the main, we are not literate enough on those issues, right? Now, the issue of substance abuse is a very, very serious one. And it's clear also it's a lucrative business, right? The fact I indicated earlier on that these inpatient facilities that are not registered, and the unregistered facilities are not limited to that, and even community-based ones, there are those that are not registered. But the act is there, that they should be registered. And whenever they are reported, efforts are made to clarify the process of registration, right? And it's one of the reasons we also support and welcome that it should be reviewed and be revisited, that is the act, and be amended in order to clarify roles. Social workers are not trained and they are not meant to enforce the law. They report on these issues and the process that these facilities are not registered. What do they receive? What do they get in turn? They're threatened. And it will lead to other issues. I'll just park that on that one. Well, as I indicated on that, there are also cultural ramifications relating to mental health issues. I mean, we're a diverse community, society, and these issues in terms of life skills, they have not been sort of embedded in training, in upbringing, and all those issues. You know, people with mental health issues, they are put in the fringes of society. And even families, they tend to hide them, etc., all those issues. So those are the challenges. The question of sharing information, well, I think that because we're in a number of platforms and we're in a number of joint campaigns, efforts are made to actually to share information and etc., all those issues. But the reality is, let us confront it. The reality of austerity measures, it impacts human resources as well. It impacts warm bodies on the ground. I welcome what we heard says that they've got about 700 community workers in Mitchell's Plain and Khayelitsha. I can venture to say, I don't think that the social service, social development can match that on the ground in terms of, for example, community development workers on the ground who are responding in a whole range of community challenges. So those are the realities, because for social development, the emphasis would be in terms of legislation, for example, on child protection, as opposed, for example, to be looking at ramification of mental health, etc. Passing to the next slide, I'm getting now to crime prevention program, because we were asked to address what we have on the ground to address these challenges. Now, again, let me explain this thing this way. In our program, that includes victim empowerment, substance abuse program, and crime prevention. Crime prevention is actually at the lowest rank in terms of budget allocation, right? And most of that budget is directed at children in conflict with the law. And you will immediately appreciate that why that is so is because that is statutory. Because in terms of the law, we are required that every arrested child must be assessed by a probation officer. a report is produced, is assessed, is taken through the criminal justice system for purposes of diverting that child. That is the law. So most of our resources, they are devoted to that. Those children, they are taken to our facilities, they are taken through to our diversion programs, etc. Then what is left of our budget is crime. We do crime prevention at schools, and we involve the youth in holiday programs, and we further involve them in, we work with the Chrysalis Academy to support youth at risk so that they don't fall into crime, and they are further assisted to go, for example, to FT colleges, etc. We have got our youth cafes that deal with them to access job opportunities, etc. So we work in a number of schools in Khayelitsha to deal with crime prevention. There are a number of them in culture. We work with them, both primary and high school, and is actually helping them a lot. But what we have picked up, and we are exploring that for further collaboration with education, because the school-going children who are above 15 at the age of 16, apparently in terms of the act, they are not compelled, that is in terms of the Education Act, they are not compelled to be at school. So there's a lot of loitering around, and the expectation is that social workers will come across those children and take them to opportunities, etc. I'm saying that that's an expectation, but unfortunately that's not the reality, because the social workers, they don't go up and down the streets picking children who are in the streets. That's the reality. Probably if there were community development workers in communities doing that and what, one would argue that perhaps that is in our lap as well. But let me leave it there at that. So in terms of crime prevention, we do it, and then we do it also for youth at our centers who are in diversion programs. And we have got accredited programs, for example, that deals with substance abuse, that deals with gender, there's GBV issues, that deals with, for example, anger management, and basically to ensure that when they exit these programs, they are actually reintegrated back into society and aftercare, and then they are given skills as well. That is those who have graduated from our diversion programs. And ultimately, in terms of the act, their criminal record has to be expunged so that they are able to access job opportunities. That is in terms of our crime prevention program. These programs, they are there in Khayelitsha and in Mitchell's Plain. Now, I'll move now to victim empowerment. Well, if victim empowerment is one of our most successful programs, we work with the victim as they access our points. If they are brought by SABS, for example, we work them, we take them to shelters. If they via True Health, we take them from our Tutuzela care centers. Just to sketch the picture, this information is recent, where it was shared by NPA at our victim forum. That was yesterday. They say that Brema, right, which takes cases from Mitchell's Plain and Khayelitsha, it had the statistics of 1,063 matters. These are matters of domestic violence and matters of sexual offenses via that is the Brema. And the Khayelitsha, via the Tutuzela centers there were 532. So there's an increase of numbers. Well, our explanation for that, one, we know now there's this national strategic plan on GPV. So there's a greater awareness and for people to access services. Now, of course, there are challenges that they are picking up where the NPA has raised them, and then we will address with the NPA. Those challenges, for example, they relate to the preparedness, for example, of children who come from Tukuzela centers to engage the criminal justice system, because they have to be prepared. And the issues they are raising, they're quite critical. They relate to the standard of reports that are submitted to make to make that report meaningful to the judiciary. In other words, we have found that now it requires it will require training by judicial officers, that is to empower social workers to be in a position to write those reports that will stand the scrutiny of the court. Because of high levels, from the health report, it was quite clear that trauma plays a major issue in these issues. And it's quite clear that trauma, if we check the levels of violence in our society, they are horrific. It was reported recently that South Africa ranks 19th in the world in terms of organized crime. Now, if you check the prevalence of these unregistered facilities, substance use facilities, it's quite clear that organized crime is there. And the threats they are making, our social work, I cannot send them to some of those areas unaccompanied by SARS. And there are instances where you find that the people who are running these things, they are known, but nothing happens to them. Because if in terms of organized crime, we are ranked at that level as a country, that's a horrific picture. And people complain, there come these complaints as ministerials, they want officials to be sent to the area to investigate. Newspapers come, they come with their own deadlines that we're giving you so many sort of hours to run the story. And then with all those constraints in resources, you are expected that to run around to check and report on that ministerial. Clearly, I mean, those things, if they are not checked, they will compromise our social workers. Because remember, I indicated we care. It's one of our values. It's caring for our staff and caring for our communities. But if you put them under pressure in this sort, it's not going to work. Now, I move now, and our social workers are trained. They are trained on trauma-informed care because it became quite clear that they are not in a position to manage the high levels of stress in our communities. So they are trained. We organize service providers to train them in order to be in a position to handle these issues of trauma. But we're dealing here with problems of scale. Honorable members, I suggested in one of Imbizos, Minister Cele was there, that it is high time that legislators attend Imbizos. Because that was a college. When I looked around, there were no members, there were no legislators. It's high time that they attend these Imbizos so that they hear directly. Because the defense of Minister Cele was that what can they do with Minister of Finances presented the budget? I said that no. He was evading the issue because the issue is, budget in the final assessment is adopted by Parliament. It's parliamentarians who accept austerity measures, and they expect officials to do the impossible. No, that one I cannot accept it and take it. We try the best we can do with innovation to ensure that we collaborate to the best of our abilities. and ensure that we do the impossible to stretch the resources to the limit. Whilst on that one, let me also come to this question of the GBV. We are present in Mitchell's Plain, we are present in Khayelitsha, we work with NPOs in Khayelitsha, with Mosaic, they are doing wonderful work. We work with families, right? Let me, members of, honorable members, indicate that it's troubling us as well. The issue that how does it happen that government invests in kids in early childhood development? These very same kids, they come into conflict with the law. They commit horrible crimes, murder, and that's what put burden at the hospitals. But we ask the question, why? It's clear, but it will take additional resources and research to understand why these 16-year-olds, they are out of school when they're supposed to be at school, or all those issues. Hence, the whole of society approach is partly the solution to that, but we're talking here of scale. And the colleagues, let's face it, honorable members, these issues I'm referring, I'm putting here on the table, they were there before COVID. They were there before load shedding. In load shedding and the COVID, they merely complicated a complicated situation. Now it means that we are expected and we've been told that we cut and reduce. And remember, the very staff that is supposed to implement and deliver on these issues, they're not highly motivated, because when there's a freeze on wages and all those things and prices are escalating, right? What are we going to get? Colleagues, let us be on the same page. We're working with people here. Surely they will react, surely they will do the minimum. I just wanted to say something very, very positive about a recent evaluation, an M&E that was done in Mitchell's Plain at a drug sort of facility we support. That report says that the organization we are funding has got a very, very able board. That board is familiar with the field of substance abuse, is doing great work, but of course there were gaps we identified that they need to be corrected, such as updating their policies, such as ensuring that the OAH, as they are sort of in place, those policies, and then they are well displayed. But overall, they are doing good work. So in conclusion, honorable members, I'm saying that in collaboration, because when we deal with substance abuse, we are also working with the city of Cape Town. They have got about 8 facilities that is in the metro area, and then those facilities, they are accessed by the communities in Khayelitsha and in Mitchell's Plain. And then we have an MOU with them. And also we're also working with the Western Cape Liquor Authority to ensure that they address these issues that were experienced in East London of kids who died in that club, at that tavern. They are addressing those issues where we are on the same page with them, and they are renewing their licenses, and they've taken a view that there will be no automatic renewal. In other words, the non-compliant liquor authorities, they have to justify why their licenses should be extended. These measures and interventions, they are important because there are high levels of alcohol abuse in the country and in the province in particular. So we need everybody, we need all stakeholders on board, and we need liquor authorities, taverns as well, to work with us, not against us. Thank you.
Thank you, Mr. Gaba. Just in addition to Mr. Gaba, I also want to say we have a inpatient treatment center at our facility side of social development, and there we also accommodate 30 female adults. We are busy, or we are in progress to build a new facility for the males. So currently we alternate from females and males in that center. And then also for youth, we offer in our child and youth care centers awareness programs, various awareness programs for substance abuse. And we also have a youth facility that take 50 substance abuse children. Thank you.
The other point I need to add here is that because of the problem or the challenge of substance abuse, a number of communities, they want these facilities in their areas, right? And clearly it's not sustainable that in each and every community you can have a substance abuse facility. And the emphasis is on community-based services. We are rolling them to the extent of our budget in a number of communities. Obviously, for historical reasons, they are concentrated in the metropolitan area, but they are accessible, for example, in terms of if people they can be transported to access those facilities here, that is in the metro. But they are a challenge, and communities are raising those issues. And our advice is that those issues, they should be taken to IDP forums, platforms, because we hope also the district model will alleviate some of these challenges. Because if there's an agreement that a particular area needs this facility, and the stakeholders in it, they are agreed, then there should be no problem to support it. And we will also request that the committee could assist us. You know, Public Works, we are saying this thing from experience, because at the height of GPV, we received 6 facilities from Public Works. They had to be improved to be in a position to operationalize. Now, we would recommend strongly that Public Works should be persuaded that these facilities that are no longer in use, they should be renovated and to be put in a position that if communities want them, that is municipalities, they are able to utilize them. Because if the expectation is that they will just take them, they will not have budgets to immediately utilize those facilities. Thank you.
Thank you very much to the Department of Social Development for your input, also giving the committee insight this morning into the services that you render in that specific areas. And I think our focus were basically on the 2 areas transpiring from our oversight visit and what, as I said, as a committee at the time, what we witnessed. And but I think going forward, we will want to have a broader picture in terms of the entire province. So I'm not going to be unfair. I'm going to give Member Kego an opportunity, and then Member Windvogel, and then I will raise my questions. Please proceed, Member.
Thanks, Chair. And thanks to the department for sharing their frustrations with us, because it is very clear that indeed they are working under frustrative circumstances, with lack of resources, with a lot of challenges that they've made us aware of. But what I would want to understand is especially around the issue of the stigma. You know, the challenge that we would find in our societies is that there would be facilities availed and services availed, but our people not utilizing them on the basis of being stigmatized. So, and then it would mean, or it would send the wrong messages if departments are failing, or even those institutions are just standing as white elephants. I just wanted to understand in terms of, because you did appeal to us to be participating with the different government spheres, especially with regards to imbizos, so that we would be able to understand the challenges that are out there. But how do you publicize and market these institutions? And of which, in terms of budget and everything else, we might find our appeal to different departments to be able to assist. I want to understand in terms of doing away with the stigma to popularize these institutions that are there. And furthermore, if we can be able to, you've listed a number of institutions here, if we can have statistics. Lucky enough, the lady over there did make mention of certain institutions, that how many are they dealing with, they can be able to deal with, if we can be able to know all of them, that each and every institution can be able to assist so many, so that we would know the need that is out there. And lastly is that you mentioned of network of 26 shelters available for GBV victims. And in our communities, we're dealing with serious challenges of GBV on a daily basis. Where are these GBV shelters being found? If we can be able to know, because the number is fine, but where are they? Thank you very much.
Thank you very much, Member Kergel. Member Windvogel.
Thank you so much, Chairperson. Chair, I'm sitting here and I'm thinking, how can we bring these two departments together to assist each other with the current problem that we are facing. Mr. Swartz and Mr. Binza, David Binza, mentioned during our interaction and oversight that some of the patients are ready to be discharged, but where are they going? I'm not sure. Where do you, when you discharge a person, where is the person going to? Now I hear from this Department of Social Development, they are mentioning they do have a type of program in-house, I'm not sure how do they call it, program. Is it possible that the department, when health is discharging those who are ready to be discharged, that the Department of Social Development take over of taking those patients in and see how can they assist those patients? I also wanted to understand in terms of the safe houses that you have in the metro area, because that's where we are focusing on the metro, the Mitchells Plain and Khayelitsha area. Do you have, how many do you have? Because it's part of the program. There's all the safe houses that are available. The fuel that was mentioned is full. Are you planning to have more, or what plan do you have? Because there's a problem. With our last oversight visit, I'm not sure, is it under the bridge somewhere here? I'm not sure the name of that safe house. People are sleeping in front of the doors to get space. Sleeping, waiting for space there. So I really want to understand in terms of the plan, of the social development plan, if it comes to safe houses, because it's a challenge and it will also assist the Department of Health with this mental patients. Thank you, Chair.
Thank you very much, Member Windvogel. We are also fortunate to have the Standing Committee Chairperson for Social Development, also part of our committee. Honorable Plato is online as well, if he would want to add anything. Just to latch on to what Member Windvogel said now, we also were informed that once an individual are classified as a mental patient, that person can also not be absorbed in the safe house system. So that person ends up back on the street. So that vicious circle start again. If you can perhaps just give us insight into that. And what we wanted to hear from the Department of Social Development specifically today was in terms of that social determinants, that factors that contributes to the health system being overburdened. So you gave us the outline in terms of programs of what you do, but I think we wanted a more high-level approach to perhaps you informing us, and you still have the time to do so. What specifically are those factors? How does it come? How does it boils over to the health system? And then I think also important, we spoke about money earlier on, and if we don't have budget, we're not able to do the necessary. So in terms of budget, what are the budgetary allocation to, I would want to know in terms of funded crime prevention programs, the second one in terms of funded victim support services, and the third one in terms of funded substance abuse services in the areas of Khayelitsha and Mitchells Plain. And also my second question would be then, or my third question, are there any programs where social development works directly with health for mental health services specifically? And then now I recognize the Honorable Baku Vos. I do not see any other further hands. Let me just check online as well. No other hands, so we'll conclude with the question session with you, Member Baku Vos. Thank you.
Thank you, Chairperson. Chairperson, I just been reminded of our oversight, whereby there was a girl who were supposed to go home, but unfortunately there was no one to fetch her, and she got furious. And she's a committed person when she does her work or her cures according to the center that they were staying at. But that day she couldn't take it. She became furious, and then she was isolated. If I'm fine because of that. Yeah. So if I remember, I think it was 1999 or 2001, while there was a patient, I will say a patient, but we call them Idandukan children. Remember Ukopi and Mbele at Lindelani place of safety, and they have the same problem. A mental health problem. I'm not sure if you are still taking in people like that. Then in the institution, there were nurses, there were psychologists, there were OTs, like in the mental health. So I'm not sure if social development is continuing with that program. If I can be clarified on that one. Thank you very much, Chairperson.
Thank you very much, Member Baku Vos. I'm giving over to Mr. Gaba, the department.
Well, let me deal with the one of how we market our services. Well, our services, we market them on our website, and then we have our call center, and then we are also linked to the GBV command center, where they refer cases to us, and then we make a follow-up on those cases, and then we report back to them on their finalization. And then we also have through our communication, especially focusing on substance use disorders. We do that on a regular basis, and then there's also Kimucha program. And then we were just about, but what we're discussing now is the timing, because we're about to roll it to schools, but unfortunately, it coincided with their exams, preparation of exams. So there's something we have to work out, but we will be implementing that as well. And then they are also participating with SAPS, where we will also market these services again. SAPS nationally, they are rolling a program. It's called, its theme is make sport your gang. Is to address gangsterism. So here in the Western Cape is around the 5th of December. So the intention is that all Provincial departments participate in that program. And then we, as I said, that we are using various platforms and social media, and we are also working with. We see that our strength lies in partnerships. So we work with NPOs and other community service organizations who are doing their work, who are also linked with UCT, and we participate in those presentations they organize. For example, there was the one that was presented by the Department of Criminology from UCT. They were presenting their research, a research they have done in Khayelitsha specifically. It was about gangsters in Khayelitsha, to understand how these good gangsters emerge and why, what is driving them. And then they found that in terms of that research, it was a question of safety first, because one wants to be safe. If you are not in a particular gang, you are not safe. It was also a question of status, and then it affected them attending schools. You see, so those are the issues. And then also we have found with the Department of Education, we will be exploring that work further, because they have understood that the kids are dropping out of school. So before they drop from school, they start them in programs to say that what are you interested in? If you're interested in plumbing or in whatever, instead of just letting them drop, they sort of work with them. So we'll be working with education around that. And also the reason why we will be working with them also is because it was raised earlier on by health that we find that one psychiatrist being in charge of 3 facilities, that's humanly impossible. So we have also found a situation of that nature that social workers in education, they are thinly spread. I mean, they are spread over a big area, and then we tend to complement them as such a social development. So that's what I will answer this question of how we market these services. Now, the other one we wanted to deal with, we wanted to capitalize from the experience of the Victim Empowerment Forum. I indicated earlier on, is quite successful in terms of its participation and in terms of the work it does, and in terms of sharing best practice. What we would like to do with health, I think it would work, is a question to have a referral pathway that has to be agreed between the 2 departments, so that if a person is admitted in a mental health, that person is coming from a family or from whatever, then there must be a referral pathway to say that when that person is released, a social worker in that particular service delivery area will be notified, so that that person doesn't fall in the cracks. Because if that person, for argument's sake, does not have a family, it means that the person will be back to social services in a shelter of social services for further monitoring. So that one we will explore. It's good that there's that meeting, that high-level meeting of SODs, They must resolve that at that level. You get the point. But we can also do it as ourselves as implementers. But it's good when it is backed at that level. Because those people, they cannot be released just open into the streets, you see. And indeed, you see, if one looks into other jurisdictions, budgets that are spent on mental health, we must Google in America under mental health, you will see the money they spend on mental health. There are serious mental health issues in America. Probably the reason is because they've been in too many wars. That is their soldiers. So they've got a lot of budget dedicated to deal with mental health issues. I'm not sure this is the case here. And you will see that reality is concerning. So the issue has to be elevated to be surfaced of mental health. That is a serious challenge, and we need to work with that. Do you have anything to add there? Or the statistics, we don't have them, but we will submit those statistics. Safe to say that each shelters, our approach to shelters is this. Let me explain it this way. Each shelters in our province, they are owned by individuals, that is by NPOs. They are not government shelters. Even those that were donated by the Department of Public Works, national and listed to the province, they are managed by NPOs who are funded by DSD. There's no shelter that is managed by DSD staff. That is, they are operating and running a shelter. And of course, we see that as a challenge, because if you go to rural areas, if you take services to rural areas, the challenge we get is very difficult to retain staff in those areas, or for staff to go to those areas in the first place, to incentivize them to go there. So it means that one way or another, you cannot dispense with a government facility. You see, so a shelter is not, in many ways, is not different from a clinic or a police station. You see, because these things will always be there. You can try to reduce them. You see, so the committee could help with those issues. You see, because really, the first defense, these public assets, they should not be released to whoever, right? The vulnerable need them. And because we've got a significant number of people who are unemployed, especially the youth. You see, if you check in this research, they will tell you people who are driving, these drivers, they were asked, these drivers who are driving this is the youth. Between the ages 16 up to 24, they are the people who are driving crime, and then who are victims. You see, and they become a problem of health. You see, and when they come to us, what do we do with them? We don't have a budget to give them skills except these expanded public works programs. We do intervene here and there, but we see a big player here being economic development and Department of Labor. They must come into the party, you see, because we don't create jobs, unfortunately. You see, but we do where we can assist in providing these shelters to women who are abused and women. And that question that was asked, the drivers for social development, in the realm of social development, domestic violence. You know, during COVID time, when people they were under lockdown, it increased. Simply because people they couldn't stay together. You see, so that's a serious challenge. You see, but we have started in the department, for example, what we call the courageous conversations with departmental staff first to address these issues. The understanding being that they will be extended as members of communities, they will be extended to communities. So we've got a tendency of saying that, okay, people, they must be volunteers in communities. No, it can't work that way. People, they need bread. So we don't have a number of volunteers on the ground as we would wish to have them to do this work. You see? Because even, I'm sure even if a person, the other issue that was raised with correctional services, which is a serious issue, but in legislation it has been accommodated, but implementation is another one. We were told at one meeting that there are about 3,000 parolees who have been released. Now, those parolees, the issue here was that the victims were not informed, the neighborhood watchers, they were not informed, that is community structures, they were not informed. Now, it means that now we have to close the gap there. Unfortunately, they are on the party. They are also members of this committee on cultural and social ills. So we'll ensure that whenever they release people on parole, the victims are tracked, they are part, they are on board to facilitate integration into communities. Thank you.
Thank you, Mr. Gaba. Thank you, Chair. I'm going to answer the question of how do you bring these departments together. I think we are currently working together on a lot of topics, including mental health. We have a mental health steercom committee meeting, which are held by our HODs of our different departments, and there they discuss all the challenges. We also have an intersectoral committee in place where we discuss children with disruptive behavior. On that committee is Department of Health, DSD, Department of Education, and there is where we discuss children with disruptive behavior and mental health in terms of who and where lies the responsibility, where we're going to start and where the child is going to end up. And I think it's really very useful. And then Ms. Barker-Force asked a question in terms of 2001 when we had a mentally challenged child in Lindelani. Copy, yes, we do still have that in place. So we have all our centers, different centers. We accommodate the children with mental health challenges in our centers. I must safely say that almost 80% of our children are children with mental health challenges. And the same as my previous colleague said, we've got huge problems with maintaining our assets, dealing with the other children that don't per se have mental challenge, but are there for some other reasons. And it's difficult, but we manage. What I can also say, there is nurses in our facilities and there is OT still in our facilities, but we need referral pathways to mental health. Our challenges is really overcrowding. Everybody wants to place a child in a facility. We struggle with that. We also struggle when we need to place the child back when there's stability. Maybe a child that needed Ritalin because of an ADHD. We place the child in collaboration with health on Ritalin. Child is stabilized. Now we struggle to place the child back with the family members. And unfortunately, we sit with a huge waiting list in terms of mentally challenged children to admit to our facilities. And that is why health is also struggling with bed space because they need the children out. We struggle to get the child in the family. So I think in our intersectoral committees, that is some of the challenges that we speak and discuss in that meetings. Okay, I hope I answered that question.
The other thing on the substance, on the drug master plan, we are in the process of receiving comments from stakeholders. We've done in-house as a department. Now we're receiving comments from members of the forum. We'll make the document available as soon as it is adopted to members of the committee.
Thank you very much, Mr. Gaba. I've also made a note that we, during our resolution session as the committee, also asked for the determination of the mandate of those forums that was mentioned. At this point, I'm going to ask the representatives left of the health department whether you perhaps have any input in relation what the Department of Social Development has said this morning. Anything from your side? Sure.
Thank you for the comprehensive overview. In terms of the population, Lentegeur sees adults and children, and the same for Valkenburg that only sees adults, and Stikland. What is the services for adults within that area of Mitchell's Plain and Kailicha, male and specifically males? What services are available for them?
Thank you. Anything from your side, Jan? You covered, Mr. Suarez?
Thank you for the opportunity. Also, just to make some comments. I know from my side, it's a lot, granular in the Mitchell's Plain area, and I do know of 2 areas where we can refer patients. Is Matrix. The other one is Sultan Bau, that is supported by DSD. And I also know that those facilities are also full all the time, which makes those referral pathways difficult. They are there, and I agree that on the Steercom and the higher levels, we must work closer together to improve that. Because when we talk about the mental health care, I think the overlap between health and DSD are on not on the clinical factors, it's more on the social determinant factors, and that is where we will have to work together, especially in the drug problem before the patients reach the emergency centers. And then, you've got 2 cohorts when it's time to discharge. You've got those patients that is going to be discharged to a tertiary facility because they've got some deep lying mental health illness. And then you've got some patients, the majority of them, that is going back in the community. They may be landed up there because of intoxication or drug abuse. And this is where we now need to work with our colleagues in the DSD to create that pathway. Where do we send, these patients? Because these are the patients, like we've said, because of all those social determinants in the community, that if we don't hold them there, make sure they get their treatment and actually in some sort of a program, they definitely will come back in and be a burden and potentially take up a space of somebody that's more critical need. So that is where we're overlapping here in the social determinants of health as it affects the mental health and wellness. So I agree there's work to be done on that higher level Steercom to give us in the district hospital that, because I know how my colleagues in the primary health care, because these are now patients ready to go home, they will normally facilitate with the DSD where these patients can go to, and the facilities are mostly full. So this patient that might be ready to go into some sort of a service is now blocked and probably might find themselves down the same path again. So I think going forward, and where you come in, is to assist, to even force the 2 departments to work together. But the work is already being done. That has been noted. So I know that there are some 2 institutions that we can send patients to. I mean, we're talking about patients that don't have funds or medical aids to access of the private facilities, of which there are quite a few. But for those patients that don't have access to that resources, is very little, and they are overpopulated. So that is a space that we need to work into and plow resources into if we want to protect our health system, for what I would call, your more clinical factors. These are kind of social determinants, self-induced mental health patients because of our communities. Thank you for that.
Thank you very much, sir. Ms. Dean at the back.
Thank you so much. Thanks to our colleagues from social development. And it is true that we have been taking hands in particular spaces, and I just foresee that will deepen the problem with children getting stuck in our facilities at Lentegeur particularly. We had a very high-level meeting with the HOD of social development about 2 weeks ago, and colleagues from social development and health, and we are looking at ways of helping and sorting out this problem. And I do believe that will deepen going forward. But there is obviously more work to do. And in the substance particularly, I think that is another opportunity where we have to get together and say what our role is versus yours. I think we know it, but just again to cement that connection. So I look forward to those invitations as well as a department. Also just want to take the opportunity to thank you for this opportunity.
Thank you so much, Ms. Dean. Ms. Kivitz?
Thank you, Honourable Chairperson. Just a few questions. The Kailicha Mitchells Plain area, Chrysalis is funded by what I'm of the opinion is funded by social development. Do we have a clear indication of how many of our youth that is in conflict with the law and placed in families? Do we have any idea of the intake from Kailicha and Mitchells Plain in the Chrysalis Academy program? And then the official spoke about community development workers versus community health workers. I mean, it's not a problem that social development is not aware of. It's been years that the discussion around community development workers has been on the agenda. So how serious are we of addressing the social ill at traffic lights, in parking areas, dropout of schools with the Department of Education, if social development is aware of the problem, but the problem is not being addressed by making sure that we have foot soldiers on the ground? Because I must commend the Department of Health that maybe everybody's not trained in mental health, but there are soldiers on the ground where social development don't have those soldiers on the ground. And then the referral pathway versus the social worker reality for communities. I'm in the Belhar area and we have a family constantly at the traffic lights, and it's a father with 3 children. I referred the matter. It's almost a year later. The father with his 3 children are still sitting at the traffic lights. So I was told to refer to Belhar, I was referred to Kudut. Are we serious when we address issues around children vulnerability and the impact of mental health on kids? Because those kids are possibly being used to sit at the traffic lights because there's no other alternative. And then my last point, it's again with regards to vulnerable children in the Kailicha Mitchells. It's a pity it's only those 2 areas because the disparity is possibly in all our communities, not just Kailicha and Mitchells Plain, because if we look at Delft is at the moment the biggest integrated population in the metro and possibly in the province. And yet we see the same problems presenting itself in the community of Delft, and it's not getting the same attention as the other 2 areas that we are currently under discussion getting. So my concern would be if we are talking about interventions, family interventions, we also see year after year that social development is not spending the budget that they have for their family program. Are we serious about family integration? Are we serious about addressing the challenges around mental health with families? Because I have seen a lot of families don't understand. And culturally, families sometimes don't understand because they think their children has been bewitched or something like that. And so how do we ensure that when we talk about families, that we have an integrated program between the different intersectorial groups and clusters? Because even for the steering committee, the Department of Justice, it's a national component and it's not in the room talking about the challenges around mental health.
the water systems, but she doesn't walk through the...
Can you kindly mute yourself, please? Thank you very much.
So I think, Honourable Chairperson, it's important that we look, if we talk about intersectorial, what role does the community and NGOs form within the intersectorial cluster? Because it's good to talk about us, but if we're not part of the discussion, how do we address and minimize the complexities that we have in communities? Thank you.
Thank you very much, Ms. Kivitz. I see Mr. Caesar's hand is also up. Please proceed, sir.
Thank you very much. I think I just want to reference the two questions from Honorable Windvogel around the spaces at Lentegeur. And the second question in this round was, how do we bring these two departments, together? And I want to reflect on how we did things in COVID. And in COVID, we had real operational meetings. We had representatives from various departments putting our heads together and engaging with communities, and we came up with solutions, and we did really well as a, if I may say, a WOZA and WOGA. We really responded well. We maybe didn't achieve our targets 100%, but we made a good impact. So I want to speak from an operational responsive process and saying, if Lentegeur has spaces, if DSD have challenges, and our focus today is Khayelitsha and Mitchell's Plain, and can we not come together and meet and say, what additional programs can we collectively pull together in an operational space so that there are responses to all these questions that's being asked? I want to then, through the chair, ask for us to move into an action space. Before I ask, yesterday we were in Indaba, the head of health in Indaba. One of our challenges was the political will for us to proceed. And through the chair, I want to ask, can we not get someone from the standing committee and say, we will invest some time as a chairperson to pull the stakeholders together of Mitchell's Plain, to pull the stakeholders together of Khayelitsha, and let us talk about real solutions, real responses, so that we see this impact in our community. And I think that's probably the space that we need to move to. And in that space, we're going to answer all these questions within context of specific communities, with our specific challenges, because we do have rich data as a Department of Health. We do have rich data as a government. So let's use it and move forward. So that is probably my challenge I want to put to the Standing Committee of Health and say, take our hands, come beside all of us, and let's do this together. Thank you.
Thank you so much for your input, Mr. Caesar. Mr. Gaba, just on Ms. Kivitz's...
Thank you, honorable members, for the questions and the inputs. Just to let on, indeed, it would assist a great deal for resolutions of this committee, because specifically we're discussing these two areas, Mitchell's Plain and Khayelitsha. That was the focus of the presentation, that they are taken back to the area-based teams, which are based on the lessons of COVID. To say that these are the real challenges. And then we often find that a situation crops in that the real challenges on the ground, they may not necessarily match what has been put on the APPs, right, as the real issues. That's another issue, but it's important that these resolutions they be taken to that level. That's when then they will actually respond. Now, this issue of, I would recommend to the honorable member that this question of street children, I mean, this specific family with 3 kids on the robot, perhaps maybe it should be raised as a ministerial to the minister, where there will be an obligation for staff, that is for us to go to the area to investigate and address that matter and bring it to conclusion, to finality. We have agreed with education, we have got an understanding with the Department of Education that we should address truancy in schools, which manifests itself, among others, as kids who are loitering around robots, doing all those things. We have agreed to pilot that intervention in depth, but it is at the level of operationalizing it, because it means then that there have to be dedicated staff appointed to do exactly that work. So yes, depth is one of the areas, and that in Bizo was a depth where serious issues were raised. There are serious issues at depth. They were raised around justice system, the fact that there's no court in the area. They made a commitment that they will build one. They were raised issues around social development, the fact that after certain times social development is not available, is closed. You see, so there are a number of issues that were raised at this business, and of course we report to the point, but above that there's a need to monitor the implementation of those issues. So resolutions from this committee will go a long way to address that. Well, a question of not spending budget on family, that one will take forward with the family program and try to understand it. For example, our crime prevention strategy is informed by the understanding that the family is the cradle of nature, and a lot of ills and dysfunctionality revolves around the family. So it's difficult to understand that a budget on the family is not spent, you see. But as I said, that we need to check that, perhaps what are the reasons for that, because there's a lot that can be done around that budget if it is not spent. Prevention programs, surely they need it. Reunification and reintegration interventions, they need it. So it's difficult to understand that there's a, but I'll check with my colleagues in the family program to understand. But also important to explain that our substance abuse program is also extended to shelters, to people who live on the streets, in the shelters. It is available, the interventions we do. They are not just left in the cracks. Of course, that population of people living in shelters is growing, and it simply indicates the challenges faced by the country. And of course, more is required, unfortunately, to deal with those issues. Another thing. Chrysalis, let me indicate this way. Chrysalis is funded by community safety. And the main focus of Chrysalis is youth at risk. They were very, very, very reluctant to work with the youth already in conflict with the law. But now they are coming to the party, where we'll be working with them on joint programs, but is at the initial stages, that program. Yes, because it's an important resource in the province, that is Chrysalis Academy. And indeed, there's a case to be made for the youth in conflict with the law to be beneficiaries of that program. So we have just started working together with them, and perhaps it could come as a resolution as well that at a certain point we need to report to the committee how far is that work. Thank you.
Thank you very much, Mr. Gaba, and I will leave that to the Social Development Committee to follow up on that specific request. The Honorable Plato is online, so he's getting all of this. I think for us as the Health Standing Committee, we've come at the point where we will be concluding this meeting of today. But I think this is a start. And it was important for us to actually go and see and observe what the conditions are within the facilities, to hear from yourselves at the time during the visit as to what your challenges are, and today formally start the conversation, and rightfully said so that it's quite evident, Member Bakofos, that this is not a matter that stands in isolation. The mental health challenge that we are facing, it requires of integrated, holistic approach of many departments and many stakeholders as such. So, Ms. Kivitz, we are of our intended purpose. As I said, we started the conversation today as the standing committee, of which in our oversight capacity, but we also have the power, if I can call it like that, as a standing committee to influence legislation. And I think we've come at a point where we should seriously do that. Otherwise, things will continue as it is, and we cannot allow that to continue as it is. We need to vigorously interrogate legislation to make sure that what it is that we expect as society from the department itself, from these facilities, that we do our part in creating the environment for them to do the best that they can with what they have. But also, if that change cannot happen on provincial side, we should, through other means, whether it's our NCOP, our national counterparts, we should now be engaging them, because we are at that point as society in addressing the issues, if we say that we are serious about what we are doing. So I wish to thank our health department colleagues, also our Department of Social Development, for indulging the committee this morning. And this is not the beginning and the end. I believe this is the start of a very meaningful engagement with all of you and also the other stakeholders, as we will be inviting them to our next broader engagement. And I think members would agree with me that we will set enough time aside, because we will have, as I said, a much broader component. So we will need to have more than enough time to really do what we intend to do and have the necessary outcome at this point. Ms. Kivitz, thank you also to you that's always willing and able om te kom staan vir die saak. So we are really very thankful, and we'll also make sure that notice are provided to those other NPOs and so forth to also join us on the day, and we also hear their voices in the standing committee as well. So thank you very much again. You must have a blessed and a wonderful weekend. Please travel safe. We look forward to see you next time around. Thank you very much. You are excused. Members, you just need to do some committee business.
They're going to take the victims down. Then the police will open for them.
Is there still coffee at the back?
This mic is open, huh? Is it on?
Thank you for staying behind, members. We still have member Plato online. Members, any recommendations and resolutions from your side? Reference was made about the SESH study. Can they SESH study? Yeah, I don't know what that is, but it seems to be latching onto the mental health issue. So if we can perhaps get the information on the SESH study. And then there was also the question, I think, from member Van Vogel in relation to the 500 million rand, whether that was raised with Treasury. That was also not answered. It will make a difference. Mm.
Or if I'm not sure if the budget ends, but my understanding is the regional hospital is giving more service. But the type of services that they're giving is more comprehensive than one on every country of this.
So how will that difference between the two impact on the mental status? Is that what?
I want to assist
Okay.
with the influx or the situation at this
You've got that?
So what's the resolution?
No, I want to understand because my question to them was, what is the view of the department if we make a district hospital sitting with this challenge of overflow of mental health patients, if we change it to regional hospitals?
I think this question was raised by one of my kids when we visited Mrs. Plain. But now,
But that was probably a verbal answer. We can ask it formally.
Yeah, okay. So,
You've got that one. And then also the 2022 drug master plan. If we can have that. Damaris.
They don't empower their social auxiliary workers to manage when they face situation like mental health. If they can at least top up their training when it comes to the social worker and child care workers, because even in the institution, in their institution, we do have abantwana aba-mentally distressed. They must just top up their training. It will reduce the burden in the
How do
training
we,
plan.
How do we, do you have that, Namonde?
so yes, it will empower their social auxiliary and social workers of mental health.
Yeah,
That
do they have
also-
a training plan
Yeah,
for
that
that?
latches onto the training, yeah. And their training, what does they, are they trained?
they always say they facility. There are buildings that remember, next door, in the land, they say, big institution there. It was called Siakatala. They don't do anything, everything huge. And we work, maybe now, we no longer
Condition.
yeah, but if they can
Should we then ask
and employ more, remember we spoke about this. This is that even at school, even teachers, you know, when I was speaking to school, she told me something and I realized people get stressed. That's why they have to keep it. She said, look, Baku is no longer getting the land in hand. She no longer say. Caretakers are teaching the children. You see, that thing, the stress will make them do that because they can't do it, because they were not trained enough to.
So the next to Lindaland, there's a big building. It's called Siakatala. DSD to get it, so DSD must get this building.
Yeah.
And do what in that
Say,
get the building.
Yeah, can we then perhaps just
But it needs to go to Public Works.
Yeah.
DSD does not own any building.
Yeah.
They get it from Public Works, and usually Public Works will say they are planning to do something.
to do
with it.
something? Yeah.
They can request.
Can we just can we just add to that, Namonde, the acquisition of buildings for this financial year, so that they just not only respond to that, but if they are intended, to have other buildings acquired,
Which is now such Public Works.
Public Works, yes, for this purpose of safe houses, so that we get a broader picture if there is plans on the cards.
So acquisition buildings.
Yeah.
For safe houses
Yeah.
in the province.
In this financial year. Member Van Vogel?
They can, social development also can give us a breakdown of the auxiliary, what do you call them? The auxiliary workers, how many do they have? In the province. And then Chair, perhaps.
They must tell us where.
Yeah, and where.
Areas,
In where,
yes.
yeah. And perhaps also not Dr. Swart, the direct, what do you call them, from Mitchell's Plain Hospital mentioned something about there need to be engagement with the HODs from the different departments. So if our committee can initiate that type of engagement, because it needs more senior people to take this forward, and the HODs will be the best from the different departments.
Yeah. I think what we have concurrence as a committee as to in what direction we are driving this whole mental issue and having other departments on board as well. But I think for the coming week, Namunde, okay, you will be on oversight away, but we must see how best we can have a draft program specifically for this issue that we are addressing now. And as Member Van Vogel is speaking about, at what point are we including who, in which session? When are we having the other state departments? When are we having the NPO, that grouping? When are we having those high-level discussions where we have both ministers and HODs present as well? But we'll try and work on a draft program to incorporate into our entire program.
So the high-level discussions will be on mental health issues.
Yes, we are driving this one now.
Listen, you also mentioned something about we need to influence NCOP in terms of the legislation. So we also need to look how are we going in terms of a plan, or how are we going to do it?
Process.
Process.
I think we should have our WCPP perhaps, I'm not sure whether it's our legal department, whether it's PO, but that can give us direction in terms of the process. Should we want to propose amendments from the Western Cape side? Our delegates that side, the process in terms of, yeah, just giving us insight into that as well. And then there was also mentioned.
Which act do you want to amend? The mental?
I think we need to speak to the mental. We will also have to have a briefing on the act itself at some point. Because when I read it and you read it, we will get different interpretations. But we will have someone that can actually brief us on the act. We can raise our questions and at least have a better understanding of what the act currently says before we can propose amendments to it. There was also made mention of units coming on board in this financial year. When it comes to units, was it mentioned about wards at these facilities? Can we perhaps just direct that to the department? How many units will be coming on board in this financial year?
Right, on the process for the amendment of the national mental health. I think this one.
Hello.
I think this one via the NSOP permanent delegate. But Chair specific, what will we did not get from the department? What is it? So, now, okay. We did not get to the in terms of this mental health act. What needs to be amended when we make that?
That's why we're gonna have the briefing on the act itself first.
Oh, okay.
Yeah. The impact. That you will take up with Honorable Plato, your friend. Member Plato is hearing you, Member Pakufos. Is that our is that the lot? Member Plato, anything from your side?
Yes, Chair.
Please.
Yeah, thank you very much. I concur with the issues raised, with the recommendations and so on. Just pertaining to, if Monday could make me a summary of 3, 4, 5 of the key issues pertaining to social development, I would love that. And so that we can pay attention to the social development issues. We had a study group meeting this morning, a number of issues discussed, but I did ask earlier today for a special social development study group so that we can filter in some of these latest issues as well for discussion with Minister Shana Fernandez. Thank you.
Thank you very much. Honorable Plato, and Namonde nodded her head. She will do so for you.
Thank you.
Member Fry, anything from your side?
Nothing from my side now. Thank you, Chair.
You covered. Thank you very much, colleagues. That is, I think we will still give opportunity if something perhaps crosses your mind until coming Monday at 12 o'clock. Please forward to Namonde if you think about something in the meantime. Colleagues, we are now on the agenda on point 3. And we're dealing now with a draft committee report on the COVID-19 stakeholder engagement. You will remember we had that engagement in Mitchell's Plain on the 15th of June. Do you have any inputs? Page 1, just give us what I have just mentioned. Page 2, please check your attendance. at this engagement? It says from the DA, myself, Member Mackenzie, Honourable Plato, and from the ANC, Member Van Vogel. Do you have any amendments to page 2? I do not see any hands. Page 3. Nothing. Page 4. And page 5. Members, can we move to adopt this report?
Yes, Chairperson.
A report of the Standing Committee on Health on its
stakeholder engagement. That is how we write here.
It's right as it stands there. It's right as it stands there. It is correct as it stands here.
Maybe the
Typo on your side, perhaps. Yeah.
Where is which one?
Which word are you referring to, Member Van Vogel? What is the word that doesn't have the spacing?
It's your on stakeholder.
Ours is right.
Ours is right, yes. Yeah, perhaps it's just a printing issue. Yeah. Member Plato proposed that we adopt the report, and seconder from Member Van Vogel. That deals with that one. Colleagues, 3.2 is the draft committee report on the joint visit on the Standing Committee of Health and the Standing...
The report there for Member Van Vogel because he raised the... So which one? Oh, okay.
With the printing.
Oh, okay.
Thank you. For the Mitchell's Plain engagement. Monday, will you just check?
I did not get the approach. Usually I register when I get. We will have to double
Okay,
check.
we'll have to double check. Okay, so if it wasn't raised, you must be cross with Member Van Vogel. Okay, Monday we'll check.
No, there was no apology, Chair.
No apology.
Usually I bring it.
Okay,
forward.
then unfortunately there's no apology, Member. 3.2 deals with a draft committee report on the joint visit of the Standing Committee on Health and the Standing Committee on Social Development to the Overberg district from the 22nd to the 24th of June 2022. Members, you have been furnished with the report. First, you'll find the cover page. Please check your attendance on page 2. Present was myself, Member Mackenzie, Member Plato, from the ANC, Member Baku Vos, Member Van Vogel, Member Brinkhuis at the time, as well as Member Tego. Any amendments on page 2? I do not see any hands. On page 3, page 4, page 5, page 6, page 7, page 8, page 9, page 10, page 11, page 12, and this report will be signed off by both chairpersons, myself and Member Plato. Members, can we move to adopt this report?
Yes, Chairperson, yeah.
Proposed by Member Plato, seconded by Member Van Vogel. Thank you very much. That deals with that one. Members, 3.3 deals with the draft minutes of the committee on the 29th of July. You've also been furnished with this documentation. Please check your attendance on page 1. Myself and Honourable Plato, Member Van Vogel, Member Barnes was also present, and an apology was recorded for Member Kego. We had the Provincial Council on AIDS and TB Secretariat present to us, which was Ms. Nikki van der Walt at the time. Please check page 2. Do you have any comments or amendments? Page 3 and page 4 just for signature. Members, can we adopt the minutes of the 29th of July? Adoption proposed by Member Winvogel and second by Member Plato. Thank you very much. Members, then we have the draft committee report on the visit to Khayelitsha and Mitchells Plain District Hospitals, which occurred on the 3rd of August. First page of the report is just indicating such as I've said just now. Page 2, please check your attendance. Was myself, Member Plato, Member Mackenzie, Member Winvogel, Member Barnes, and apology tendered by Member Kego. Members, page 3, any comments, any inputs, any amendments? We move over to page 4. I do not see any hands. Page 5. And page 6. Can we move for adoption, members?
I propose.
Thank you, Member Plato. Seconded by Member Winvogel. Thank you very much. And then we move over to the draft minutes of the 5th of August. Page 1 deals with your attendance. Myself, Member Plato, Member Winvogel, Member Barnes, and absent at the meeting was Member Kego. We then had, you remember, Dr. Moodley, I think it was in the committee room, yes, that indulged the Committee on Health Intelligence of the Strategy Cluster in the Department of Health. A very insightful session that we have. Any inputs, amendments, comments with relation to page 2, members? And then our final page, page 3. If you do not have any amendments, can we move for adoption, members?
Something like this now, because
yes, Chair.
Member Winvogel, you move to adopt. Were you present, Member Baku? Member Baku, propose, and Member Winvogel second. Thank you very much. Members, our 3.6 deals with the draft committee report on the visit to Lentegeur and the Valkenburg Psychiatric Hospitals on the 19th of August. That's our covering page of that report. Page 2 deals with our attendance, the introduction and the overview on the day. Present myself, Member Plato, Member Fry, Member Winvogel, Member Baku Vos, and apology tendered by Member Kego. Members, you've received this report. Page 2 deals with the introduction and the overview as well. On page 3, the salient points that emanated from the visit to the Lentegeur Hospital. Page 4, the key challenges are outlined in 3.1.1. On page 5, proceeds until 3.1.15. Page 6 deals with the recommendations at the bottom, 3.1. Page 7 deals with the visit to the Valkenburg Hospital. Page 8 continues, and then 4.1 deals with the key challenges noted during the visit to the Valkenburg Hospital. Page 9 continues, and at the latter part deals with our committee resolutions. Page 10 is a page for signature. Honourable members, you've received the report in advance, and I'm sure you've perused. Can I have a proposer to adopt the report, please?
I propose, Chair.
Thank you very much, Member Plato. Seconded by?
I second. Member Fry. Member Fry.
No, she was not. Her name is not on.
Member Fry.
Member Fry, we hear you.
I'll second if it need to be.
Thank you very much. Proposed by Member Plato and seconded by Member Fry. Yes, Member Barnes was not present at that engagement. They were overseas, you're correct. Colleagues, our last piece of committee business is that of our draft minutes for the meeting dated the 12th of August this year. First page, please check your attendance. Myself, Member Fry, Member Winvogel, Member Tego, Member Barnes and Member Baku Vos. Member Plato, did you submit your apology at that meeting?
Yes, Chair, I did.
No, there was no.
Yes.
Did you submit to Ms. Jamke?
I will have to check, but I think yes.
I think it's a no.
Okay, you'll double check. Thank you, Member Plato. We on page 1, attendance and our departmental officials, as well as the only the heading of the opening and welcome. Page 2 deals with the briefing by the Department of Health on the name change to the Department of Health and Wellness. Briefing by the Department on the name of. I think we should add their name change. That's page 2, honorable members. On page 3, input from the community health forums and briefing by the Department of Health on the integration of the City of Cape Town clinics to the Department of Health. Point 3 on page 3, and then page 4 that continues. Page 4 deals with 3.2. Input from the health forums also stipulated. It continues on page 5. And 3.3 deals with the community resolutions. 3.4 further requests for information. Point 4 the establishment of the TB caucus in the Western Cape Provincial Parliament. And 4.1 deals with the committee resolution. Honourable members, we adjourned at 12 on the day as indicated on page 5. Do you concur with the minutes of the meeting? Can I have a proposer? I recognize Member Baku Vos proposes for adoption. And Member Winvogel seconded. I believe, members, that is all our committee business for the day. Members have contributed with their resolutions and recommendations on our initial meeting. You still have time until this coming Monday at 12 o'clock to submit any inputs you still have on today's meeting to Ms. Jamke, please. And then, honourable members, that concludes our meeting today on Friday, the 23rd of September. Thank you so much. Thank you so much for your indulgence. Thanks so much for your valuable input. Members, it's 1:20. This is the most hard-working committee in the WCPP. Yes, I'm sure you can agree. So thank you so much for your patience. Thank you so much for your valuable input. I hope and trust and pray that you all will have a wonderful weekend, a most blessed weekend and a safe weekend. Thank you very much. Ms. Jamke, you're a star. Thank you to Ms. Burgess as well. Please drive safe, members. And this meeting is now adjourned. Thank you very much.
Thank you, Chair. Thank you, members.